हम आप सभी को बताना चाहेंगे कि माननीय मंत्री महोदया डॉक्टर भारती प्रवीण पवार हमारे बीच पधार चुकी हैं और अब से कुछ ही पलों में हमारे बीच इस हॉल में जुड़ने वाली हैं। आप सभी से हमारा एक बार फिर अनुरोध है, अपने अपने स्थान पर शीघ्रातिशीघ्र बैठ जाएं। स्थान पर बैठ जाएं। जैसा कि आप जानते हैं कि इस स्वागत समारोह की मुख्य अतिथि हैं डॉक्टर भारती प्रवीण पवार, माननीय केंद्रीय राज्य मंत्री परिवार एवं स्वास्थ्य कल्याण मंत्रालय। माननीय मंत्री महोदया अब से कुछ ही पलों में हमारे बीच इस हॉल में पधारने वाली हैं। आप सभी से हमारा अनुरोध है, कृपया जल्द से जल्द अपने अपने स्थान पर बैठ जाएं। already arrived here at the venue and has been in the exhibition area and is all set now to join us inside the hall. पधार चुकी हैं माननीय केंद्रीय राज्य मंत्री परिवार एवं स्वास्थ्य कल्याण मंत्रालय भारत सरकार डॉक्टर भारती प्रवीण पवार। हम माननीय मंत्री महोदया का हार्दिक अभिनंदन और स्वागत करते हैं। Ladies and gentlemen, we warmly welcome in our midst Dr. Bharati Praveen Pawar, the Honorable Minister of State for Health and Family Welfare, accompanied by Shri Rajesh Bhushan, Secretary Health and Family Welfare, Ms. Roli Singh, Additional Secretary and Mission Director, National Health Mission, Dr. P. Ashok Babu, Joint Secretary, RCH, Ministry of Health and Family Welfare, and Dr. S. K. Sigdar, Advisor, Family Planning and Maternal Health, Ministry of Health and Family Welfare. We extend a warm and hearty welcome to all the dignitaries on the dais. Namaskar. Dignitaries on the dais, dignitaries of the dais, distinguished guests, ladies and gentlemen, welcome to the National Summit on Family Planning. Sustaining efforts, steering partnerships, shaping vision in family planning, sabka saath, sabka vishwas, sabka prayas, sabka vikas. Ladies and gentlemen, as India is a signatory to SDGs and we have a vision to reach them by 2030, today's summit is a step in this direction. We extend a warm and hearty welcome to the dignitaries on the dais once again, and we welcome them with a green gift, a piece of Mother Nature herself. We warmly welcome in our midst Dr. Bharati Praveen Pawar, the Honorable Minister of State for Health and Family Welfare. We extend a very green welcome to you, ma'am, with this plant. Our warmest welcome to Secretary Health and Family Welfare, Shri Rajesh Bhushan. A green welcome to you, sir. A hearty welcome to Ms. Roli Singh, Additional Secretary and Mission Director, National Health Mission, Ministry of Health and Family Welfare. A very warm welcome to you, ma'am. Our warmest welcome to Dr. S. K. Sigdar, Advisor, Family Planning and Maternal Health, Ministry of Health and Family Welfare. After extending a green welcome to the honorable dignitaries on the dais, it gives me great pleasure to welcome in our midst Ms. Roli Singh, Additional Secretary and Mission Director, National Health Mission. In her vast career spanning almost 28 years in the civil services, she has worked across various sectors including health, medical education, women and child welfare. May I now invite her to deliver the welcome address. Please put your hands together and give a warm welcome.
Very good morning and a very warm welcome to Honorable Minister of State, Dr. Bharati Praveen Pawar ji, Secretary Health and Family Welfare, Shri Rajesh Bhushan sir, my colleagues from the government, various development partners, implementing agencies, academia and the media representatives. Thank you for taking out time for this very important and well-timed summit. As we are all aware, 2022 is a landmark 75th year of India's independence. It also marks 70 years of implementation of India's family planning program. It has been a fruitful and an exciting journey, and it has been made possible by the hard work of our health workers, generations of health workers who have toiled day and night to achieve their goal. Family planning has always been a policy imperative for the Government of India. And as we all know, India was the first country in the world to launch a national program way back in 1952. The International Conference on Population and Development, ICPD, held in the year 1994 at Cairo, Egypt, led to a paradigm shift in the implementation of the program. The new approach had a very strong reproductive health orientation, and the target-based approach was replaced by a decentralized community-led planning with a needs assessment approach. The program has come a long way, and currently it has been repositioned not only to achieve population stabilization, which has socio-economic implications for humanity, but also to reduce maternal, infant, and child morbidity and mortality, if we look from the health and the SDG standpoint. The activities of the program are geared towards achieving the goals and objectives as stated in various policy documents, the National Population Policy 2000, National Health Mission, National Health Policy 2017, and to honor the commitments of the Government of India, including ICPD, SDG, and the others. As we all know, the SDGs to 2030 accord considerable emphasis on universal access to reproductive health care services, to which this program is geared. FP 2020 platform brought a much needed momentum for ensuring universal reproductive health care across the globe. India committed to improve contraceptive access, access to hard to reach areas, expand contraceptive basket, strengthen our supplies, increase awareness generation and strengthen counseling services, enhance private sector participation, and address the needs of young population and ensure adequate financial commitment. India 2020 journey was marked, FP 2020 journey was marked by successful completion of India's commitments made at the platform. The FP 2030, the new global partnership for family planning, seeks to build on the strengths and successes of FP 2020. We are aiming at building strong and sustainable partnerships between governments, civil society organizations, and strengthening the role of civil society groups in promoting family planning. During the past decade, we have made significant gains in family planning as a result of concerted efforts of all the stakeholders, most of which are who are represented here. The recent National Family Health NFHS 5 shows the country has achieved replacement level fertility. As many as 34 out of 36 states have shown an increase in modern contraceptive use, and 28 out of 36 states have shown a decline in unmet need, and that's a huge achievement. However, being a country of 1.4 billion, we cannot afford to rest on our laurels. The need of the hour is dedication to reliable data and evidence, whilst embracing inclusion, transparency, and mutual accountability. Providers must be empowered, trained, and have an enabling environment in order to achieve this goal. We must assimilate lessons from prior and current program metrics and identify and reward quality from service sites and providers. I believe there is a clear imperative to complement our different caregivers and recognize their efforts in India's family planning journey. It is with this objective that we are honoring our champions today. I take this opportunity to congratulate all of you and thank you for your perseverance in the face of the challenges. And thank you once again, Madam Honorable Minister of State and Secretary, for being here in this gathering. And I hope that we have a fruitful discussion, at the end of which we have a clear way forward to honor our commitments in FP 2030. Thank you.
Thank you, ma'am. Ladies and gentlemen, we have the pleasure of having in our midst this morning Shri Rajesh Bhushan, Secretary, Ministry of Health and Family Welfare. An IS officer, prior to joining the Ministry of Health and Family Welfare, he was Secretary in the Ministry of Rural Development and in the Cabinet Secretariat. In his more than 3 decades of public service, he has served both in the state and the union government and has served as an administrator and a policymaker, having held a wide range of assignments in the field of information, education, transport, rural development, and health. Please extend a warm round of applause as I request him to articulate his thoughts.
Honorable Minister of State, Health and Family Welfare, Government of India, Dr. Bharti Praveen Pawarji, the Additional Secretary and Mission Director, National Health Mission, Roli Singh ji, Dr. Sikdar, ladies and gentlemen, it is indeed a pleasure to be part of this gathering today on what we call the National Family Planning Summit. What we must realize today as we interact and initiate this dialogue is that family planning program in India is now more than 7 decades old. So there have been in the last 70 years lot of learnings, and we have, based on those learnings, refined this program as we have progressed in terms of its coverage, in terms of commodities, in terms of our messaging, in terms of research, so on and so forth. The second thing that we must reflect on and take satisfaction in is that India was probably the first country in the world to launch a national, pan-national program on family planning. So that lent a particular structure to all the interventions that different stakeholders were taking, both within the government and outside the government. The third important thing that we must realize and reflect is that in these 70 years, we have, based on our experiences and learnings, seen a paradigm shift from the concept of population control to population stabilization, and then the whole intervention being embedded in RMN, CH plus N, and we also added a as we went along. And the whole approach then was in harmony with the continuum of care. So from a population control perspective, now we are in a continuum of care perspective. So that has broadened the horizons for the multiple interventions that we do in this program with our partners, both within the government, outside the government. In this context, I wanted to take this opportunity to draw your attention to three thematic areas. There would be multiple that you would be discussing in course of the day today, but I would want to underline three. And what are these three thematic areas? The first one is that although we have achieved replacement level fertility, we do have a sizable number of people in the reproductive age group, and we must never ever lose sight of this fact, because we are a huge country. We are not comparable to any other country, a country of 137 crores. So in a country of this size and dimension, even if you achieve replacement level fertility, which we have, there still remains a significant number of people in the reproductive age group, and they must remain at the center of all of our interventions. So this is a thought that I'm leaving with you. It has multiple sub-dimensions, which I'm sure you would be discussing in course of the deliberations today. The second aspect that I would want to draw your attention is that traditionally our focus has been on the supply side of this equation. The focus is on the provider and on the delivery systems. However, now is the time to focus on the demand side, the patients, their families, communities, societies. So this is something which was there in our thoughts, but which must now be the focus. Because going ahead, any significant change, as distinct from an incremental change, would happen once you focus on this side, the side of patients, families, communities, villages, urban areas, slums, so on and so forth. The community-based approach under Mission Parivar Vikas was extended. It started in a gradual manner. It was extended to 13 states, Dr. Sigdha? Yes, 13 states. But since we have the state representatives here, I would urge the state representatives to make special efforts to leverage the provisions of this scheme, to refine the scheme further, utilize resources from the state also and from other development partners, and ensure a greater coverage. So this is the second thematic strand that I wanted to leave with you. The third one is that the pool of family planning service providers should not be allowed to shrink as we go ahead. When we talk of FP 2030, providers must assume a significant role. This number is indicative of our capacity to deliver. Deliver what? Deliver the services which are required. The knowledge, the skills, the motivation of this workforce is paramount to maintaining efficiency and quality in our program. And efficiency and quality must remain the cornerstones as we go forward. So therefore, a properly trained and a competent workforce must be the foundation on which the future of family planning would be built in the coming 10 years. So these were the three thematic areas that I wanted to focus. Let me again reiterate that I am not even for a second saying that there are not other areas which are not important. You see, coming from the domain specific knowledge area that different tables here represent, you would think that your own domain is the most important, and I do not fault you for that. However, from a national perspective, I thought that these three thematic areas must be highlighted, and I wish you well. I hope the deliberations today are mutually productive and fruitful and would contribute and add value to the efforts of the union government going ahead. Thank you.
Thank you, sir, for your presence here today and your words of encouragement. Ladies and gentlemen, the family planning program in India has a rich history of more than 7 decades. Vision, commitment, and carefully crafted strategies over decades have helped in adding new dimension to the program and thus making India not only a forerunner to introduce the first national program in the world, but also helping it emerge as a global leader to provide learning platforms to the entire world. Through this audiovisual presentation, we have tried to capture and showcase the remarkable journey and progress of family planning program in India. May I request the audiovisual team to play this audiovisual presentation.
भारत, हमारे लोग हमारी ताकत है। जब लोग आगे बढ़ेंगे तो देश आगे बढ़ेगा। इस बात को भारत सरकार ने समझा और 1952 में भारत विश्व का पहला देश बना जिसने परिवार नियोजन कार्यक्रम को अपनाया। इस ऐतिहासिक पहल के बाद पिछले कुछ सालों में कई नए और जरूरी बदलाव आए, पर सबसे बड़ा बदलाव आया पिछले 8 सालों में, जब RMNCH+A और FP 2020 ने फैमिली प्लानिंग को एक नई दिशा दी, जिसके बाद से परिवार नियोजन को मां और शिशु के स्वास्थ्य के नजरिए से देखा गया और साथ ही परिवार नियोजन कार्यक्रम के अंतर्गत कई बदलाव लाए गए, जिनके कारण गुणवत्तापूर्ण सेवा आज गांव-गांव तक उपलब्ध है। इन महत्वपूर्ण बदलावों में कुछ अहम बदलाव थे। परिवार नियोजन के तरीकों में बढ़ोतरी, इंजेक्शन और छाया को उपलब्ध कराया गया, ज्यादा प्रजनन दर वाले राज्यों में मिशन परिवार विकास को लाया जाना। 2016 में एक बड़ा अभियान शुरू हुआ जिसमें बताया गया कि परिवार नियोजन केवल महिलाओं की जिम्मेदारी नहीं, बल्कि पुरुषों की भी इसमें भागीदारी अनिवार्य है। अलग अलग माध्यमों से ये बात लोगों तक पहुंचाई गई। 2 बच्चों में अंतर और शादी के पहले साल में परिवार नियोजन पे बात हो, इस पे भी जोर दिया गया। परिणाम स्वरूप भारत ने फैमिली प्लानिंग 2020 के सभी गोल्स को पूरा कर लिया। देश की जनसंख्या वृद्धि दर अब रिप्लेसमेंट फर्टिलिटी रेट तक आ गई है। 31 स्टेट्स और यूनियन टेरिटरीज रिप्लेसमेंट टोटल फर्टिलिटी रेट तक पहुंचे। मॉडर्न कॉन्ट्रासेप्टिव की पहुंच 57% तक पहुंची। 5.7 करोड़ अनचाहे गर्भ और 20 लाख असुरक्षित गर्भपात रोके गए। सरकार की पहल के अंतर्गत 1.5 लाख हेल्थ एंड वेलनेस सेंटर्स द्वारा जन जन तक सेवाएं पहुंचाई गईं। प्रधानमंत्री श्री नरेंद्र मोदी के नेतृत्व में आयुष्मान भारत योजना के तहत भारत अब अग्रसर है यूनिवर्सल हेल्थ केयर की तरफ। सतत विकास लक्ष्यों को प्राप्त करने और सबको साथ लेकर चलने के लिए प्रतिबद्ध है भारत सरकार। परिवार नियोजन के 70वें साल में हमारा संकल्प और मजबूत हुआ है और हम तैयार हैं इसमें नए सुनहरे अध्याय जोड़ने के लिए। आजादी के इस अमृत महोत्सव पर आइए हर नागरिक हर संस्था व हर संगठन संकल्प ले कि परिवार नियोजन को हमें आगे ले जाना है, भारत को आत्मनिर्भर बनाना है, विश्व को नई दिशा देना है।
Ladies and gentlemen, on this historic occasion here today, we shall witness a series of launches of various materials and booklets which will serve as guidelines for future. The London Summit on Family Planning marked as a cornerstone to provide impetus to the national agenda of family planning across countries in order to revolutionize the global vision of protecting children and mothers dying due to unhealthy spacing and lack of access to family planning choices. India has continued its effort to expand the range and reach of contraceptive options through rolling out new contraceptives and delivering a full range of family planning services at all levels, and it has already transitioned from FP 2020 to FP 2030. The FP 2030 vision document highlights the commitment of Government of India in evolving family planning needs and strategies to address the country priorities. May I request the Honorable Minister Ma'am to kindly release these documents. First, we have the India Updated Medical Eligibility Criteria Wheel 2022. The wheel contains the medical eligibility criteria for starting use of contraceptive methods. It has been adapted from WHO MEC Wheel for Contraceptive Use 2015 update. This updation covers India's own indigenous product, Cantacronan, India's Make in India product. Ladies and gentlemen, we are now witnessing a release of launches of various materials and booklets which will serve as guidelines for future. Thank you, ma'am. Ladies and gentlemen, we shall also be witnessing e-launches, the digital interventions. The vision of Honorable Prime Minister towards Digital India program is to transform India into a digitally empowered society and knowledge economy. To achieve this vision, Family Planning Division, Government of India is also contributing by launching e-module of FP-LMIS, MEC Wheel application and digital archive. I'll be requesting the Honorable Minister Ma'am to kindly release the e-launches with the press of a button. We start with the medical eligibility criteria, that is the MEC Wheel application. The MEC Wheel application is an e-version of Medical Eligibility Criteria Wheel 2022. This will help healthcare providers to deliver quality service. The e-module Family Planning Logistics Management, that is the FP-LMIS system. This comprehensive e-module on FP-LMIS manual seeks to provide information on the supply chain management. The Digital Archive, Family Planning. Family Planning Digital Archiving is a repository of digital materials of Family Planning Division, Government of India. Ladies and gentlemen, we shall now have e-launches related to empowering community. As we all know, community interventions are one of the most important pillars of any public health program. Family Planning Division, Government of India gives utmost priority to the community interventions and its primary stakeholder, which is the community. May I once again request the Honorable Minister Ma'am to kindly, with the press of a button, release these e-launches. We start with the National FP Helpline Manual. The National Family Planning Helpline has been started to strengthen the information, education and counseling services regarding the use of family planning methods in the country. The Community Health Officer Booklet. As part of Ayushman Bharat, the community health officers have been deployed and are playing a critical role of family planning services, comprehensive primary health care. Asha brochure and leaflet. Asha brochure will provide brief snapshot of family planning methods and its benefits, timings, warning signs and effects. We are thankful to the Honorable Minister Ma'am for doing us the honors. Ladies and gentlemen, we also honor here today some achievers who have shown us that the path to success is the result of perfection, hard work, learning from failure, loyalty and persistence. And as they say, coming together is a beginning, keeping together is progress, and working together is success. It's time to honor the achievements of those who worked relentlessly to achieve these goals for the entire nation. I request the Honorable Minister Ma'am to felicitate some of the achievers who are here with us today. We have the FP State Awards and citations. May I request you, ma'am, to please join us center stage and forward to present the awards. We start with the Family Planning State Awards. For male participation, put your hands together for the first prize, which goes out to Chhattisgarh. तालियों से उत्साह बढ़ाना मत भूलिएगा. And for male participation only, the second award goes to Telangana. For PPIUCT services, please put your hands together for the first award winner, Tamil Nadu. And the second prize goes out to West Bengal. For the expansion of Antara program, put your hands together for the first winners, Meghalaya. And for expansion of Antara program, put your hands together for the second winners, Rajasthan. For uptake of self-care methods amidst COVID-19 pandemic, put your hands together for the first winners, Jharkhand. तालियों के जोश में कमी मत आने दीजिएगा, आपकी तालियों से इनका उत्साह बढ़ता है. Put your hands together for the second winner, Assam. For the adoption of spacing methods and healthy birth spacing, put your hands together for the first winner, Delhi. And second winners in the adoption of spacing methods and healthy birth spacing, put your hands together for Jammu and Kashmir. We now move on to individual awards. For vasectomy, put your hands together. In the first place, we have Dr. Yakub Pasha Hanumukonda from Telangana. And for vasectomy, the second place goes out to Dr. Sanjay Naval from Raipur, Chhattisgarh. And I've been just told that Dr. Yakub Pasha Hanumkonda has performed 40,000 procedures. That's a record in itself. What an achievement. We're now joined by Dr. Sanjay Naval from Raipur, Chhattisgarh, and he has won himself the second prize for vasectomy. I believe Dr. Sanjay Naval is not here. Moving on. For female sterilization, first prize goes out to Dr. Mohan Soni from Indore, Madhya Pradesh. For female sterilization, the second prize goes out to Dr. Ram Naval from Maharajganj, Uttar Pradesh. For nurse in Antara program, the first prize goes out to Ms. Karan Kulkarni from Bidar, Karnataka. The second prize in Antara program goes out to Ms. Jyoti Rani Haldar from NNM, Andaman and Nicobar Islands. And moving on to For Nurse Antara program, the first prize has been won by Srimati Manju Kumari from Bihar. She has just received her prize. And now joining us, NNM, Andaman and Nicobar Islands, Ms. Jyoti Rani Haldar. For Asha, put your hands together in the category vasectomy. The first prize goes out to Ms. Kevira Bai from Raipur, Chhattisgarh. The second prize goes out to Ms. Geeta Suryavanshi, Gwalior, Madhya Pradesh. In the category HWC, from Bargarh, Bhandaria district, Garhwa, Jharkhand. That concludes the felicitation for all the achievers who have gathered with us here today. Let's Once again, may I request you all to give a rousing applause to all the achievers. Ladies and gentlemen, it's been an absolute pleasure to have in our midst today the Honorable Minister, Dr. Bharati Praveen Pawar. A brief introduction to the Honorable Dignitary before I invite her to share her thoughts with us. She was elected as member of Nashik Zilla Parishad in the year 2012 and got re-elected from Nashik Zilla Parishad in the year 2017. And she was elected as a Lok Sabha MP from Dinodri constituency in Maharashtra in 2019. And ladies and gentlemen, it gives me great pleasure to welcome the Honorable Minister to address the August gathering. Please put your hands together and give a rousing welcome.
Thank you, Mandeep. Shri Rajesh Bhushan ji, Secretary, Ministry of Health and Family Welfare. Mrs. Roli Singh ji, Additional Secretary. Shri S.K. Sikdar ji, all the friends who are gathered here for this National Family Planning Summit. Namaskar. And my all friends came from all the states and UTs. I extend a very warm welcome to all of you and thank you for this participation in this National Family Planning Summit. Friends, India understood the importance of family planning early and went on to be the first country in the world to launch a national family planning program in 1952. We have come a long way since then, striving to ensure universal access to family planning services. I am glad to say that as per the latest survey reports, India has achieved replacement level fertility with as many as 31 states and UTs having achieved a total fertility rate of 2.1 or less. It is happy to note that modern contraceptive usage has increased substantially to 56.5%. National Family Health Survey 5 also shows an overall positive shift towards spacing methods which would be instrumental in impacting positively the maternal and infant mortality and morbidity. Friends, these gains are a testimony to the systematic efforts of national and state governments in the spirit of cooperative federalism as well as manifestation of dedicated efforts of our million-plus field health workers under the visionary leadership of Honorable Prime Minister Shri Narendra Modi ji. Today, family planning is globally identified as a key initiative to reduce maternal and childhood mortalities, and I must say that population issues are not just related to number of people, but its impact on demographic, health and socio-economic indicators like age at marriage, sex ratio, mortality, fertility, etc. The increasing population also sheds light on health problems faced by women during pregnancy and childbirth, making the need for family planning, gender equality and maternal health more important than ever. Friends, the need to control population explosion today is most desperately than ever. As the Government of India gears to celebrate and commemorate the 75 years of independence through Azadi Ka Amrit Mahotsav celebration dedicated to India's population can't be missed. The awareness created today will provide result in better health infrastructure, educational institute, a better quality of life for the generations to come. Friends, India being a member of Family Planning 2030 partnership has invested 3 billion USD in family planning as a part of its commitments to the partnership. I'm proud to say that during the tenure of 8 years, that is from 2012 to 2020, India added more than 1.5 crores additional users of modern contraceptives, thereby increasing the modern contraceptive use substantially. The population and development debate in Indian context has been rather interesting to study and is reflected in our population policies. Our Honorable Prime Minister has addressed the issue many a times in his speech and has actively created awareness about the population control. Friends, in my opinion, population cannot be controlled by force. Rather, it is only the awareness that we share the limited amount of resources will help bringing down the population. Policies of government have also been designed in a way to encourage population control. Programs like Mission Parivar Vikas in 2016 have given further impetus to the National Family Planning Program. Under the scheme, innovative strategies like distribution of Nai Pahal kits, Saas Bahu Sammelan, Sarthi vans are helping to reach out to community and initiate the dialogue on family planning, healthy birth spacing, and importance of small families. I am happy to note that more than 17 lakh Nai Pahal kits have been distributed to newlyweds, over 7 lakh Saas Bahu Sammelans conducted, and over 32 lakh clients have been counseled through Sarthi vans since inception. It is a result of this that NFHS 5 data shows a substantial increase in modern contraceptive use and decrease in unmet need in all MPV states. I am glad to know that we have witnessed an impressive decline in fertility and maternal mortality in last few years due to strengthening of medical facilities and health infrastructure. It is also a reflection of strong political will, improved governance, provision of finances, meticulous planning, implementation and effective monitoring with the strong foundation laid by our Honorable Prime Minister. Hence, in order to build Atmanirbhar Bharat, the need of our is sustaining efforts, steering partnerships, shaping vision in the family planning with the philosophy of Sabka Saath, Sabka Vikas, Sabka Vishwas or Sabka Prayas. Friends, this is a vision of our Honorable Prime Minister who has initiated Swachh Bharat Abhiyan, Fit India, Khelo India and Yoga which embody promotive and preventive healthcare in bid to address health issues holistically. Nearly 1.2 lakh of the 1.5 lakh health and wellness centers under the scheme are operational and delivering comprehensive primary health care. Family planning is included as the central element in the package of services. In order to achieve the goal of universal health care, the government aims to not only strengthen existing strategies, but also nurture the innovations in the arena of family planning to improve literacy of girl child and address socio-cultural barriers. Friends, it is important to remember that any endeavor for the people can never happen without the people. Hence, the mantra of Azadi Ka Amrit Mahotsav, Jan Bhagidari, with the whole of government approach, should be the bottom line of our service delivery. So, let us build responsible, responsive, and accountable institutions providing safe, effective, and holistic care. Finally, I would like to conclude by expressing my heartfelt gratitude to all of you for sparing your valuable time today. And once again, I reiterate the government's commitment to work towards improving the health and well-being of our people. Dhanyavad, Jai Hind, Jai Bharat.
Thank you, ma'am. Ladies and gentlemen, we would like to share with you that the Honorable Minister, ma'am, won herself the Best Woman Parliamentarian in the Lok Sabha in 2019 award, and she received it from the Honorable Vice President of India. Heartiest congratulations, ma'am. And now I take the pleasure of requesting Dr. S.K. Sikdar, Advisor Family Planning and Maternal Health, Ministry of Health and Family Welfare, to propose the vote of thanks.
It is my pleasure and privilege to stand in front of this august gathering to propose a vote of thanks. I am thankful to Honorable Union Minister Dr. Mansukh Mandaviya ji for supporting this initiative, and also we really want to thank with all heart our Honorable Minister of State Dr. Bharti Praveen Pawar ji for accepting to really chair this particular meeting. This is something we are very indebted to you to you, ma'am. I'm also thankful to our dear Secretary, Mr. Rajesh Bhushan sir, and our Additional Secretary, Madam Mrs. Roli Singh, and Mission Director of NHM for their unflinching support and encouragement. Also want to thank my Joint Secretary, RCH, Dr. Ashok Babu, who's currently chairing another meeting in another venue. He has been a pillar of strength to us for running this particular program. Also thank all officers of the ministry who found their time from their busy schedules to attend this summit. It is also important for me to thank the participants and all our development partners who have really assembled here in big numbers. The last count, I have been told that the development partners contingent is more than 300 today, which is a record of sorts. And this, we really want to thank you for your dedication towards the cause of family planning in India. And we really have made remarkable progress in improving family planning indicators, but this has been possible because of each and every person sitting here presently in this particular room, as well as the millions who are toiling in the field. I thank all the state officials and service providers for their dedicated contribution. India did successfully achieve its FP20 commitments, and as a result of the concerted efforts by all stakeholders, also like to thank the major supporting partners for FP20, the UNFPA, the USAID, the Gates Foundation, Packard Foundation, and other major agencies who have been supporters of Family Planning 2020, as well as now 2030 globally. The FP20 vision document, the India Adapted MEC Wheel, as well as other documents have been released in the summit, which you have seen. And I want to thank my team for really tirelessly sitting through and compiling and really coming out with this wonderful sort of a document, which will be sort of a blueprint for us to go ahead, take it forward. Also grateful to the World Health Organization for its support in the development of resources. I'm confident that this summit will provide an insight into the improving the program, as all stakeholders will work hand in hand for the fulfillment of the common objective of enabling universal access to family planning services. Also like to thank Family Planning Association of India for assisting us in organizing this Family Planning Summit, and the event management and the hotel staff who put in a lot of effort and work through the night to really come up with this wonderful show. Thank you, everybody. Once again, heartfelt thanks to each and everyone present over here for making this particular Family Planning Summit a great success. Thank you once again. Thank you very much.
Thank you, sir. Honorable Minister Ma'am, dignitaries on the dais, distinguished invitees. With that, we come to the conclusion of the inaugural session of the National Family Planning Summit. We once again thank the Honorable Minister Ma'am and the dignitaries who have joined us here today. With that, we conclude the inaugural session and we bid farewell to the Honorable Minister Ma'am. Meanwhile, ladies and gentlemen, may I request you all to please kindly remain seated. We are starting immediately with our next session. There is no break. Ladies and gentlemen, we are ready to start with our first session this morning. This session is entitled Who, What, Where, When, Understanding Current and Evolving Trends for Contraception. Please, may I request you all to please kindly take your seats. We are ready to start the session. I'll once again request members of the audience who are standing, please kindly take a seat. There is no break. We are straight away starting with the next session, which is session 1. This session is being chaired by Dr. S.K. Sikdar, Advisor, FP and MH, Ministry of Health and Family Welfare, Government of India. I'll request you all to please be seated. We are ready to start the next session. Meanwhile, a brief introduction to the esteemed speakers of this session. Dr. S.K. Sikdar, Advisor Family Planning and Maternal Health, will be talking about the National Family Planning Program, 70 Years of Glory. We also have Mr. Martin Smith, Executive Director, Family Planning 2030, that is FP 2030, and he shall be talking about metamorphosed approach towards FP 2030. Meanwhile, once again, I'll request you all to please kindly be seated. Members of the audience who are standing, may I request you all to please kindly take your seats. We are ready to start with the next session.
हाँ तो वही कह रही हूँ, फिर स्लाइड चेंज करना ना, ये आपकी फुल स्क्रीन में है ना, तो अगर आपको
नहीं क्या होना, मेरे को वो दिखता नहीं है ना, ऐसा ठीक, ये तो ठीक है ना, अब ठीक है, ओके।
Ladies and gentlemen, once again, good morning and a warm welcome. May I request you all to please kindly take your seats. We are ready to start with the session. This is session 1 entitled Who, What, Where and When, Understanding Current and Evolving Trends for Contraception. As you can all see in the program agenda, Dr. P. Ashok Babu, Joint Secretary, RCH, Ministry of Health and Family Welfare, was to chair this session. However, he has been held back due to an urgent meeting with the Honorable Minister himself. So unfortunately, he could not join us for this session, but the action continues. We promise you a session full of deliberations and wonderful speakers to look forward to. So may I request you all to please kindly take your seats. We are ready to start the session. Members of the audience who are standing, may I request you to please kindly take your seats. And may I once again request you all to please do remember to either switch off your cell phones or put them on silent mode. This session is now being chaired by Dr. S.K. Sigda, Advisor, Family Planning and Maternal Health, Ministry of Health and Family Welfare, Government of India. May I request him to please join us on stage. We shall also be having the esteemed speakers in this session. I take the pleasure of requesting Mr. Martin Smith, Executive Director, FP 2030, to please join us on stage.
First year, second year, third year. Okay? And go fourth year. नहीं 2 year 3 year आगे भी स्पीकिंग भी है
ये तो as it is है?
हाँ ये सब
इनको तो कुछ नहीं करना
इन दोनों का सेम ये सब
We extend a warm welcome to Dr. Sigdar and Mr. Martin Smith. May I request Ms. Andrea Voinar, UNFPA Representative India, to please join us on stage. A very warm welcome to you, ma'am. We warmly welcome on stage Dr. Amit Shah, Deputy Director, USAID India. May I request him to please join us on stage. We warmly welcome Dr. Rajni Vaid, Director Health, Bill and Melinda Gates Foundation, India. I'll request Dr. Vaid to please join us on stage. Take the pleasure of inviting Dr. Anand Sinha, India Country Advisor, Packard Foundation, to please join us on stage.
Thank you.
There they are, ladies and gentlemen, the esteemed panelists. Please join me in extending a very warm welcome to them all. Starting with the session Who, What, Where and When, Understanding Current and Evolving Trends for Contraception. May I first invite Dr. S.K. Sigdar, Advisor, Family Planning and Maternal Health, Ministry of Health and Family Welfare, Government of India. He is also chairing the session, to kindly open the session and introduce us to the session. And thereafter, he has a presentation which is entitled National Family Planning Program, 70 Years of Glory.
Okay. Good afternoon once again, or good morning rather. We're still to touch the noon. And I have this onerous task of chairing this session as well as making a presentation. This has been necessitated by the fact that our Joint Secretary, who's supposed to be chairing this session, has been expressly called by our Honorable Minister for a very important work. So he's not likely to be here in this session. We will see when he comes back, he can chair another session. So that is something that we will take a call during the day. So while on this particular very august panel, I am flanked by very important people, what should I say, the movers and shakers of this world, the UNFPAs, the USAIDs, the Gates Foundation, as well as the Packard Foundation, to name a few. And we really depend on their cooperation with us, because whatever we do, we all do together. And you saw the vision document this morning, which has come out of an exercise of cooperation between all partners and hard, what should I say, very tireless work contributed by all partners. Just for your reference, we had a preliminary meeting around 2 months back, wherein we had pulled in all our important partners, 40 to 50 of them, and we sat together, we decided how to go about that vision document. How do you really come out with a roadmap to take those vision forward? So thankfully, we have come out with a vision document for which we are very, very proud and happy, not just because it's a document which has come out, but something, it's a document which is a working document, which gives us the roadmap on which are the areas that we need to go forward on. Also, another important thing what we did is that this particular document, we have included the data fact sheets of 36 states of India all together, and they are really rich resource for every state government to use, and similarly they can come out with those sort of documents at the district level also. And to start this particular, or rather to set the ball rolling, what I would do is I would take you through a small presentation where we will give you a snapshot of the evolution of family planning program in the country. What are the things that we did, what worked, and which are the places which are the areas that we need to work harder on. So I'll just now move on to the presentation. I'll move on to the podium and talk from there and take you through the presentation. I assure you it will be a good data-centric, data-driven presentation, which will tell you that how we have moved over the years. So just wait for this particular transition to the PowerPoint mode. Sorry for doubling up. Can you move the light? Okay. So you can see this particular slide, what happened then and what is happening now. So this, as I said, is a data-driven presentation, so it will be easy to understand for everybody present here. So this was, if you see in our country, the initial focus was on population control. And here, if you see in this particular area, 2016 to 21, our growth rate is 1.09, which has now come down to 0.29. If you see, this is the projection up to 2036. This projection has been given by the Technical Group on Population Projection, which was chaired by the Census Commissioner or the Registrar General of India. And this is something we are taking as a Bible for our population sort of a projection in our country. We did not venture beyond 2036 because the experts believe that projecting beyond that would be a bit unrealistic because the dynamics in our country move very, very fast. So maybe even if you project a linear one, we may end up having a lower projection lower actual data than what is going to be projected. And if you move to the next slide, if you see, our population growth has declined to 1%. That is what I was showing, 16 to 21. And where were we? We were at 2.24 in 1961 to 71. And from there, it come down to 1.9. And as I said, from 11 to 36, what will happen is that 31 crore people will be added. 50% of the population will be contributed by 5 states of India, which over here, you see the Bihar. What happened? Yeah. Take it. So you have, it's going off and on.
आप सिर्फ या तो लैपटॉप यूज़ कीजिए या क्लिक कर दो।
नहीं, लैपटॉप ही कर रहा हूँ मैं। इसको ऑफ कर दो। हाँ, हाँ, यही कर रहा हूँ। Okay, you see Bihar. It's coming. It's going off, going on. So Bihar, Uttar Pradesh, Maharashtra, West Bengal and Madhya Pradesh, these are the 5 states which will contribute 50% of that. And UP alone will contribute 20% of the population. Also the annual growth rate, if you for the states of Andhra Pradesh, Telangana, Karnataka, Kerala and Tamil Nadu, it will be 0%, which means that very soon their population growth rate is going down to go even further. And here if you see, for the other states like Bihar, UP, this is full of glitches. Okay, let's this. So if you see 1%, Uttar Pradesh, Maharashtra, West Bengal and Madhya Pradesh. So coming to the initial focus was on reducing fertility in our country. We have now, if you see, we have come down to 2.1, and that's a very phenomenal achievement for us to come down to 2.1. And so many states of our country, if you see, 31. This is very, very substantial, very, very fast, even beyond our wildest imagination. Many of the states, and fast. Coming to the next slide, if you see, the family planning program has population. So in 1950, this was But if you see the overall increasing trend in population, children has ended. Children's population has ended, it has come to a halt. And also if you see how over the years the bulge is changing in our country. So in 2031, this is the bulge that we are going to have, and the youth in the coming decades will population number, we are talking about 2.53 crores. This is the peak that we have reached, and we are going to come scope for increase beyond that. Also, if you see now, from 2011 to 21, it has increased to 360. In 2031, it would go by another 27 crores up to 389 crores. This is over this number of 389 is coming. So the we have in 1952 we had population control, followed by in 76 general welfare. In 1997 we came up after the ICPD about the target-free approach, and the 2005 was a national health mission. And going forward in 2012, plus initiative which was introduced in our country, and FP 2020 also came along the same time. So there was a synergy of actions, the paradigm shift was there. So in 2017 we graduated to universal healthcare, a glimpse of which you saw in our audio-visual presentation. Earlier we had only limited choices, 5 to be precise, but the majority of them were only female sterilization and male sterilization. Expanded to all other methods. 2 more methods have come into the bouquet. One is the injectable MPA, and the second is the Centromen. And in our pandemic also, the Centromen is something unprecedented that we have been able to do. Also, there is a shift towards a healthy reproductive health. If you see our MCP rate only 12, and then in 2015. And then in the latest round, 6, which is a hopping 8%. Small country where there is a base is low, you can get this sort of an increase of 5 to 7% or 9 to 10%. But for a big country like ours with huge population and also having a high CPR, for us to have achieved something like 8% is phenomenal. So this is something tremendous that the country has done, and everybody's present here has contributed to that effort. Also, if you see the postpartum part has increases, this is one area we have been focusing too much on the postpartum contraception, and if you see 10% to 42%, and significantly one more thing that I want to talk about is the contribution of the male methods, which includes the condoms as well as 5%, gone up to 5.9 in NFHS 4 and then 9.8% in NFHS 5. This is a huge. That's the reason we actually awarded some of our who have done wonderfully well in this arena. Coming to the next one, the last 8 years of action, we have mentioned in our video also, we really work across all facets to shape the program priorities, and we really have this 5 pillars that we talk about. We acted at the policy level, acted at the program level. Providers training is something which we took very seriously. Also, we approached the community for the first time. We entered the community, got in touch with them, came out with our innovations, and also all the stakeholders present today on a single platform. Coming to the achievements, if you see from 2000 changed, our women and reproductive health numbers have changed 32 crores to 36 crores. Your numbers from the has been our crowning achievement. It has increased from 16, which is unprecedented for us, for the method information index to go down by half in just 1 decade, and going to go down. In the modern married 51%, gone up to 57% in 2020. Then percentage share of spacing methods, which we have been really advocating for over the so many years, it has gone up from 24% to 31%, and we hope to take it up as a national level. Many states have actually crossed 50%. Then you have the users. In 2012, we had 12.6 crore and then this is increased to around 2020. Unmet need too has come down by almost 2%, and then your demand satisfaction also we've done well. Our number was 74 for SDG. It is really merging together. So the contraception part, the family planning part is really doing well, irrespective of the region or caste. So around 24 million additional users were added from 2012 to 20, and budgetary allocation, as was mentioned in the morning, 3.1 billion was something from the central funds. We did not calculate, or we do not have the data on the funds actually allocated by the state governments, which is again massive, maybe another 3 billion. But since we do not have the data, we are not writing it here. Coming to the strategies to address the access and equity and quality, we is coming over the last 10 years. So we came out with new contraceptive, mission MIS, revival of the post counselors is one area, drop back scheme, this clinical out was also very good. During the pandemic, the family as much as we had envisaged to its normal level. New media campaign, then category revival at the state and district level. This into the last 2 years, this pandemic years, we came out with guidelines on continuation of essential services during continued in the states in spite of the pandemic. That is something kudos go to who were not pandemic. They continued to provide services and continued to have this World Population Fortnights in their states. Antara RMNCHA counseling was also launched, and which you saw in the morning that for the CHOs we came out with so that they are not loaded with too much of knowledge. Coming to the positive outcomes, if you see the postpartum, around 12.8% of our institutional deliveries, PPICD was the number. Now this, at that time, we thought that maybe benchmark India, and we are almost there in now 2021-22. It's around 24% now nationally. Surpassed this number also. Doses here, I would say we have under cause of the pandemic. Go and get the injections, but now it's picking up. 21-22, you're already seeing the numbers have gone up, but 22-23 is something 1 year we think is the year of inflection, where the number will really go through the roof. Sencromen scripts, again, happy to report that we have done very well. The numbers are constantly increasing. We got it evaluated independently by agencies, and we found out that this is something, a story which really needs to be told so many times, because this is a success as far as Indian family planning program is concerned. So transitioning to family planning 2030, what did we do? On the right hand side, you have the guiding principles of our universal health care. I will not read them out. So we assimilated them in our guiding document, in our vision document. So we are addressing the family planning needs of the vulnerable population. Male participant is something which we are looking at very strongly, improving access and availability of contraceptive services, and engaging the community and other stakeholders. These are areas wherein we have built in all the tenets of the universal health care, so that universal healthcare is taken care of in our vision document also. So in FP 2030, this is India's vision that by 2030, India's family planning vision is to provide access to high quality comprehensive family planning services to all people of reproductive age group, including those from marginalized groups, by ensuring equitable, affordable and appropriate contraceptive choices and information till the last mile through improved health systems and community engagement within the country's universal healthcare framework. So this is the document, as I mentioned, which you saw in the morning, which is there in your kit, and the key strategic priorities which have been outlined in this document are the adolescent and youth, expanding the contraceptive basket, improving the quality, engaging the community. Supply chain is one area where we are still struggling a little bit. We feel that in the coming years we will do better. Male participation, private sector engagement, again another area where we have not done that well as much as we should have done. Appeal to all of you, all the stakeholders, to see how this private sector engagement increases. Data system is one area where we are working and we are getting good results. And most importantly, at the last, is the resilient health system. For the first time, we have included it in our vision document, because this is one area which is going to hit us more often now that we have learned from COVID. We have floods, we have all sorts of natural calamities also. This is one area we have come out with a chapter on resilient health system. So overall impact of family planning in our country has been that we had 150 million users in 2020, and here this is the output that we got. 57 million unintended pregnancies were averted, 2 million unsafe abortions have been averted, and 22,000 maternal deaths is something that we are talking about, that if the program was not there, we would have had a maternal death in our country of around 45,000 plus, but because the family planning program is there, we have been able to reduce it. So 22,000 maternal deaths we have reduced. So coming to the last slide, 2020 was just a milestone to achieve the universal sexual and reproductive health care, but we commit to continue with the same passion and energy till 2030, so that we can really get the goals, achieve the goals much before 2030, precisely say by 2025 only. Thank you very much for a patient listening.
Thank you, Dr. Sikdar. Ladies and gentlemen, as we all know that India is a signatory to the SDGs, which we are committed to achieve by the year 2030. Therefore, we have now our next speaker, Mr. Martin Smith, Executive Director, FP 2030. He shall be sharing his thoughts on metamorphosed approach towards FP 2030. Please put your hands together and give a warm welcome.
Would you like to give me the clicker?
It's just
Thank you for your patience.
I think I'll rather say that Martin has been a very old friend of India, and he is an overseas Indian, if I am not wrong. You are OCI, right? Overseas Indian. Right. Okay. So he has his in-laws place here in India, and we have worked around 10-15 years back, and many of the policies that we are seeing in our family planning program, like the clinical outreach team, etc. He was the head of MSI in India, so because of his interaction with us, we came out with this palliative support agencies like them. They really provided wonderful support to the program. So he's not new to India. He's somebody who is very close to our country, and his being there at such a highest level is really helps us a lot to take our program forward. So over to you, Martin.
Namaskar. Thank you so much, everyone, for your patience. Apologies for the slide deck not playing ball. And Dr. Sikta, you make my head swell, and half of what he said is not true, I have to say. You know, not down to me at all, but down to the incredible hard work of many valued colleagues that I'm privileged to have worked with here in India over the years. So, Dr. Sikta, valued development partners, Devio Sajano, colleagues, partners, friends of FP 2030, delighted to be with you all in person here in India for the first time in almost 3 years. And I bring greetings from the chair of our governing board, Dr. Medaseni Rakwita, from our executive director, Dr. Samu Dubey, and really excited to be speaking to you today about the metamorphosed approach to FP 2030. So, what is a metamorphosis? A metamorphosis is a change in state or nature. A metamorphosis is a butterfly emerging from a chrysalis. A metamorphosis is the change from FP 2020 to FP 2030, both at the global level and here in India as well, of course, as we've been hearing so beautifully in this morning's proceedings so far. And the slide deck works. Fantastic. So FP 2030 is the only global partnership centered solely on family planning. It's the successor to FP 2020, as we've heard this morning. That global movement that was launched in July of 2012 at the Family Planning Summit in London, in my hometown. Great speech from former Mission Director Anuradha Gupta in that event. Great speeches from Melinda Gates and David Cameron and Babatunde Oshotumin and representatives from the US government and a wide range of partners. A really inspiring moment. And India really is a foundational commitment maker and member of FP 2020 and now FP 2030 from the very start. And those huge strides that we've seen that Dr. Sikta took us through, MCPR goals, demand satisfied already at the SDG benchmark, tracking that very significant increase in expenditure, the inspiring approach to expanding the range of method choice. To just mention a few areas that we as FP 2020 and FP 2030 really are thoroughly impressed by. And India has always been at the center of the FP 2020 movement, member of our reference group, and Mission Director Ms. Roli Singh participated in her first governing board meeting of FP 2030 just last night and stayed with us late into the night to give her great thoughts on the future of the partnership. So I'm delighted to be here at the launch of FP 2030 and really excited on what metamorphosis we can see over the next 10 years. And so what's different? What changes? What are these changes of which I speak? Well, three things to really just quickly set out to you. FP 2030 is structured as a global support network with 5 regional hubs: North America and Europe, Africa, 2 in Africa in fact, Asia and the Pacific, and Latin America, as opposed to one centralized office, which was the approach in the FP 2020 era. FP 2030 is open to all stakeholders, not just the 69 lowest income countries in the world in the FP 2020 era, but now a much more, I would say, a much more flat structured partnership where all countries, all stakeholders that are invested in quality, voluntary rights-based family planning can make commitments, and we want all of these partners involved. And we have this new updated data framework, and we really enjoy the data consensus meetings in India every year that really speak then to the levels of the individual, the system, and the enabling environment that we really need to track to ensure we're going forwards for collective success. So What do I do? What did Chong Hee, my colleague, do? What do we do on a day-to-day basis? Well, we're mobilizing and driving those commitments at all levels, from the hyper-local, the community organizations. We had a commitment from a youth-led organization in Burundi yesterday to, I would say, the very big commitments, today's wonderful commitment from the government of India. We mobilize and drive those commitments. We collect and disseminate data. We publish our report on the global state of family planning every November. We'll publish that at the International Conference on Family Planning on November the 14th of this year in Pattaya, Thailand. We're that one-stop shop for that synthesized family planning and data and analysis, but that data comes from India and comes from the countries. It's not our data, it's the collective data of the partnership. We hold decision makers accountable. We're really excited, as part of all of the country commitments, that an accountability section on how governments will say, we've achieved these commitments, we're on track with these commitments, we're working on these, we're off track with those, that is central to the commitment making process. And we continue our collaboration and convening role as a global partnership to really get the right people together at the right time to maximize impact. And so this transformation, this metamorphosis, if you will, really then speaks to shared responsibilities and even more inclusive decision-making. We have a very diverse governing board. We're very happy that Mrs. Roli Singh is there representing the government of India. We have representatives from many country governments, from civil society organizations, from the donors and development partners, the multilaterals, and a wide range of other expertise that is really there to ensure that FP 2030 can achieve its goals. And quickly here, so these 5 regional hubs that I speak about, one is based in Washington, D.C., hosted by the United Nations Foundation. That's where Chong Hee and I work. A second in West Africa, a third in East Africa, covering the 2 sides of Africa, if you like. We will announce very soon the location and host institution of the hub that will cover Asia and the Pacific, and we have a process ongoing to have a 5th hub in Latin America and the Caribbean, which was a less focused upon area, region if you like, in the FP 2020 era, is set to be a major driving force in the FP 2030 partnership. So as of now, as of today, this moment, with India having launched your wonderful FP 2030 commitment, we have finalized commitments from 18 countries, 18 country governments. 50 other stakeholders, including a wide range of NGOs, have also finalized their commitments. So the momentum is building. And these are just some of the countries. So 18 countries now, with India added to this list, have launched their commitments, and a further 20 to 25 are in the process of finalizing those commitments, and probably a universe of another 30 or 40 are in various states of conversation with myself, Chong Hee, Dr. Dubey, and the rest of the team. So I wanted to just pull out a few highlights. I'm not going to go through all of these bullet points, but a big change from FP 2020 to FP 2030 is smarter goal setting. This document, incredibly smart in the way that it sets out the goals, incredibly detailed in the data that lies behind that, very clear in vision statement, objectives, strategies, and the timelines. And this is across all of the commitments that we're seeing. Those bold, sustainable domestic financing and commodity security commitments are central to our long-term success, as are quality, as our focus on adolescents and young people, understanding how to deliver family planning in emergency situations. We heard about the demand side earlier on from Secretary Bhushan, absolutely critical, and applying those high-impact practices, those 20 or so practices that is hard-won, scalable, clear evidence is absolutely central, and those accountability frameworks to ensure that commitments are going to be reached and that dialogue is happening, very, very important indeed. So I put Q&A here. I realize we're not at the Q&A portion, but I just have a concluding remark in the 90 seconds that I have left. So as Dr. Sigta very generously mentioned, you know, I'm very proud of my connections to India. My wife and her family are from Gujarat. I've had 20 years in sexual and reproductive health so far, and my formative years were here in India. And I feel very honored to have worked under the guidance and direction of many great leaders in the field in India, like Dr. Sigta himself, like Poonam and Sudha, Kalpana, Vinoj, Vivek, and a whole range of other colleagues who've really helped shape my career and my passion for sexual and reproductive health and rights and family planning, and I thank you all very much. And so my parting thought is around this theme of metamorphosis, because we have now a set of young leaders who are coming in alongside that set of established and important leaders that I just mentioned, and many others, who are coming in and helping to enact this change that we need to see for the ambitious goals that we've set ourselves at the global level and at the country level. And I think I feel very, very confident indeed in the ambition of India's commitment and our ability to enact that very significant change that we need to see through to 2030. So with that, thank you so much. Shukriya, dhanyavad. And back to you, Dr. Sigdal.
Thank you, Martin. I think that was a wonderful way of really telling us everything about your connections as well as your region, your evolution, everything you've covered in your presentation. And also what at the global level FP 2030 is thinking about. So we've done the Indian bit, and you talked about how you are moving on the global front. But I think you will not shy away from congratulating India to coming out with a vision document which no other country in the world has done. Am I right or wrong?
You're right.
Okay, so we are the only country which has come out with a vision document. And we were the only one who came out with a vision document in 2014 also. That he has forgotten. So anyway, so we take family planning seriously. So thank you very much. And also you talked about your data system. Data is something which we really put a lot of our effort, because without data you can't really have policy imperatives. Also about the high impact practice that you're talking about. So the states are really, I think, sort of they are the ones who are actually implementing the high impact practices, and based on that we've awarded them this year. So our criteria for selection of the state was very stringent. We laid down indicators so that in fact those documentation is extremely carefully done, so that no state comes out and says that you did not honor us. So we've done that very well. So I think now we move on to our next August speaker, and that will be none other than Andrea Weiner, UNFPA representative India. So over to you, Andrea, for your thoughts on this particular area that we are talking about. Over to you, Andrea.
No presentation. No. Namaskar. My name is Andrea Wonar, and I'm relatively new to India, even though I was a student at India Institute of Management in Bangalore over 23 years ago. So I can't convince you that I'm more Indian than Martin. But what I can try to convince you is of my commitment to family planning. My career with UNFPA began in Senegal and the Gambia, and I was a participant in the early days of FP 2020 and what we had in that part of the world called the Ouagadougou Partnership. And I moved over to Mozambique, and I saw the partnership evolve. And now I see that metamorphosis in 2030. And it's a great pleasure to see that. So I want to thank you to the chairman and to my esteemed fellow panelists, but I hesitate to call them esteemed fellow panelists, because when you get into family planning, it becomes a family. And you see the same faces at all the events, and you work together for years in many different contexts, in different hats, in different ways. But it is a family, because we all have this same vision and we all have this same belief in rights and choices. So I'm delighted to be here, and I'm delighted to offer my congratulations to India and to the partners for the excellent progress on modern contraceptive prevalence rate, on reduction in unmet need, and the decline in the fertility rate below the replacement level for the first time. This really opens up new opportunities for India. This is a paradigm shift, and this is very exciting. I want also to commend India for successfully achieving its FP 2020 country goals. The numbers are extremely impressive.
150 million married women are using modern methods of contraception, 30 million additional users since 2012. But I also want to talk about sort of the negative side, which we don't talk about so much, but which for me are so positive. An estimated 59 million unintended pregnancies averted. That sounds negative, but it's actually huge, and it's very positive. If we talk about an estimated 1.9 million unsafe abortions averted, that's huge. That's huge. And if we talk finally about 22,000 maternal lives saved, that's extremely positive. And I think we need to put it in perspective also for our public, so they understand, because I think they can understand that very easily. I think we've seen and heard much from the minister and the other interventions about the changes India has made in its policies to expand choices for women, increasingly moving towards reversible methods. Pills have been there, but increasingly injectables and implants. In addition, as has been mentioned, to better quality. Emphasis on quality from the service provider all the way through the chain. And information around these services, making it available to everybody through much more diverse means of communication. So MPV, Mission Parivar Vikas, has had a strong and solid impact. But what are the challenges? What do we have to still face? I think you know these, but I'm going to try to speak to it from a generalist perspective. Success has brought its own challenges, but we all had one that nobody predicted, and that was COVID. So the question becomes, it has put brakes on a number of indicators, although as we saw, for some methods, it's actually helped improve the uptake. So what can we learn from that? What can we learn from this disruption? How can we be more agile every day, not just when we have an intervention or a disruption like that strike? We need to really look at the needs of those who are not being reached and understand how COVID has impacted them. I'm going to talk about some other challenges. Although the unmet need for family planning is decreasing, the numbers are still huge. And as you know, I don't have to educate you on this. If India succeeds, everybody succeeds in the SDGs or FP 2030. But if India fails, everybody fails in terms of numbers. So while the unmet need is down, we're still talking about a huge unmet need amongst the 15 to 19-year-olds. It's almost double the unmet need of the adult population. And of the 3.4 million young women who want to avoid a pregnancy, only 1 million are using modern contraceptives. So that's a big gap. That's a big challenge for all of us. And we need to better understand and analyze why they're unable to access the services that they want and what are the barriers that they face. I think you would agree we can celebrate 70 years of family planning and the great foresight that the country had. But I think you would also agree that India's women and girls today cannot remain with the same choices and face the same barriers that women 70 years ago faced. And I think we see that, particularly with the heavy emphasis on sterilization. This needs to shift. This needs to shift for the new youth population. Second challenge, large numbers of unintended pregnancies, and especially slow progress on reducing teenage pregnancy. This remains a very big, harsh reality. India carries about 14% of the global burden of 121 million unintended pregnancies that occur each year. 14% right within these boundaries. Studies indicate that the unintended pregnancy is associated with lower maternal health care. It's no secret to you, poor infant and maternal health care. And so the approach that's been mentioned on universal health care, on taking a total health approach, is extremely welcome. Number 3, we've talked about it, unacceptably high burden on women. We see the extremely high levels of female sterilization. We're still even giving awards for it. That's something I think we need to look at if we want a paradigm shift, if we want a societal change, if we want the social norms to change. We need to look at what's being incentivized. What are we rewarding? We know that men using a family planning method is still very low. So with greater urgency and backed from the lessons of COVID, what can we do differently to make this paradigm shift real and to get this last, I want to say, squeeze the juice out of the lemon. You know, how can we get to that potential that we're missing? This is where we need a much bigger focus on males, male influencers, and leaders to change male and female attitudes around. 4th, women's education, social norms, and availability of services are greatly influencing the decision and choices around family planning and use of contraception. Again, it's social norms. What is the mother-in-law saying? What is the husband saying? What are the parents saying? And when the girl is faced with these kinds of social challenges, this influences her abilities. So what can we do differently? What can we do to disrupt those social norms and place a different prize and incentive on delaying births after marriage? Finally, disruptive situations like pandemics and COVID further exacerbate access to services, particularly for young women from vulnerable communities. And we've seen that, whether it's COVID or whether it's the floods that are now happening or whether it's extreme drought, these social factors compound and make these young women in particular, and young people, harder to reach. So what can we do? Because if we talk about leaving no one behind, but you'll hear me say it for the next 4 years, it's not leaving anyone behind. For me, it's really pushing people behind. Because the more we don't focus on them, and the more we allow ourselves to focus on easier to reach target groups, we're actually pushing the others behind. We're creating a larger gap. And we can't allow ourselves to do that. And I think your strategy makes it very clear. Equity. Equity is a guiding principle. So India is at this watershed moment, we know, with the total fertility rate below. The largest youth population ever, 365 million young people in this age group. And while the World Population Report might have made a big splash in the media a few weeks ago about the crisis, it's really not a crisis. It's India's gift. It's the dividend that India can use so positively. And it's the youth bulge that so many countries wish they had. So how to turn this into something positive? How to reap a triple dividend by investing in young people now, for their future adult lives, and for their children through choice and quality services. So many of the interventions that I would have referred to have already been mentioned, and I don't want to highlight them further, but I do want to give some statistics. Scaling up investments in family planning. For every rupee invested in family planning, it can save the government up to 6 rupees. There's not many investments where you get 6 times your return. I don't even know many banks that are giving that these days. So it's a pretty good one, if you think about it. And I wish the finance minister were here to hear that and to think about how this could impact India's development. Greater participation and partnerships with schools. We know India has a large school education program, but it needs to be larger. and it needs to be more adequate, and it needs to build in greater understanding of sexual and reproductive health issues and be less timid, because we know in 82 countries in the world where comprehensive sexuality education has been introduced, in no country was the age of sexual debut lower. It was always the same or later, and that led to fewer pregnancies and fewer sexually transmitted diseases. So to me, that's a win-win. But how do we convince policymakers that this is part of good health? Delaying the age of marriage of girls to 18 years is a critical pathway. This discussion is still open, and what we need to do is to convince the decision makers that India could save 5 billion rupees, 33,500 crore, in healthcare and related costs if it eliminates child marriage. So this is a multi-sectoral game that we're playing here. It's not just health, it's not just what happens in the health center. So how do we work together across ministries? How do we work together across sectors? This is the path that's open to us as we go forward. We talked about training and improvement of managerial skills of health workers and focusing on equity and customization of their service for young people. This to me is the big potential that remains for health workers. Strategizing greater male engagement, men as active partners, getting them to understand the benefits. And finally, investing in research on social norms and practices. We need to understand much better how to engage the panchayats, how to engage the women's collectives, how to engage the youth networks and those who are engaging in FP 2030 every day, as Martin mentioned, as well as faith-based organizations. They can be used much more for this messaging. So it was mentioned by Martin, in all of these initiatives, we need smarter goal setting and we need accountability frameworks. Many of us are doing these things. We're investing, but we may not know what the return on investment is. So we need to be smarter going forward with the limited resources. So with that, I want to just say that this panel and this session is about partner commitment to FP 2030 and to India. And UNFPA has been a long-standing partner of the government of India since 1974 in the family planning space. And through all these years, our focus has been to support the government in introducing quality programs, services, products, data, and evidence. We've supported the introduction of injectables, procuring the first 1 million doses, and we will continue to support that commitment of the government towards expanding the basket of choices, towards promoting new approaches such as self-care and greater use of technology, especially for youth. And finally, we will conduct research in designing interventions that can help negative social norms evolve, in partnership, of course, with the ministry and stakeholders. And we will continue to bring forward India's best practices to other partners in South-South cooperation, and of course to other countries. So let me just end by saying reproduction should be an individual choice. Let's empower all people, men and women, youth, to make those choices in the best possible conditions and manner. And let's use this strategy as our beacon, as our guiding light to help create the self-reliant India that we want. Dhanyabad.
Thank you, Andrea. UNFP has been always a very strong supporter globally for SRH for advocacy, and this is the first time we are hearing you as a country director in India, and it's the first time I think we are meeting in a physical meeting. And you came out with many issues about teenage fertility, early marriage and everything. These data are available with us, and we do a lot of data crunching. This is not something which is out of our radar. It is very much on our radar, and all our policies and programs are geared towards addressing those, and we are getting very fast results on those. You mentioned about the size that we have. We are cognizant about our size. We are cognizant about our responsibilities also. So the program that has evolved over the last 15 to 10 years rather, it has been a very structured program. Every single point that you raised has been ticked and is being followed up. You mentioned about people being awarded about female sterilization. Probably you have not understood the ethos behind that. It's not about awarding people for female sterilization. It's about people who are providing there in the hinterland where the people require it and you're not giving. When you are talking of rights, you also have to talk of rights of the people who are asking for the services. So if a woman is asking, if a couple is asking for a sterilization, as a public health care delivery system, it's my duty to provide that without asking any question. So the point is about the sterilization numbers. I'll make it very clear for the audience. All of you know, we used to do around 65 lakh sterilization in this country 10 years back. Today it is down to 30 lakh sterilization, just half. Secondly, about the spacing methods you mentioned. The spacing methods, if you have seen this morning in the presentation also, how it has gone improved. The method information index, for your information, it went up from 16 to 50%. It has not happened just like that. It has happened because of the initiatives taken by all the partners sitting over here, including yours. So maybe down the line, maybe you will be much more familiar with our program, and we will interact in much detail to think about ways and means that how can we take the gains that we have made. About the quality, I think ours is the only country we have where quality assurance committee, not just at the national level, at the state level, at the district level, we also have it at the block level. And the committees have regular meetings chaired by the collectors. So all this mechanism is driven by a Supreme Court of India. So it's a legal sort of a thing which we have. So as I said, as we discuss more and you grow familiar with our country, you will be able to appreciate the efforts of the government, because more than anybody else, we are more concerned about the situation that we are in and how we are rectifying it very fast across the country. So thank you very much for your comments. So we now move on to the next speaker, which is Dr. Amit Shah from the United States Agency for International Development, for his comments on the partnership and the support. And USAID has always been a great supporter of family planning program. We can vouch for it right from the last 2 decades. This is something, a very strong partnership, and we really value your support. So over to you, Amit, for your comments.
Thank you. Good afternoon, everyone. So dignitaries on the dais, off the dais. Am I audible? So it is indeed a privilege to represent USAID here at this important National Family Planning Summit. Let me start off with a quick quiz, a question, and would request for a show of hands. So this is the third National Family Planning Summit since 2012, since the London Summit happened. 2013 Eros, a lot of people must remember. 2016 when injectable was announced. And 22 is where in the shadow of the pandemic we are all over here. So how many people have attended all three summits? There is a prize at the end of it. So not, okay, great. So for all of you, post lunch there is a photo op with Dr. Sikdar and unlimited access to contraception from the National Family Planning Program till the time the next summit happens. So on a personal note, this invite is very, very special. It's been a 10-year-long journey since the London Summit. So many familiar faces over here, Jyoti, Poonam ji, Kirti, Archana, Medha, Deepa, Ram, Anand over here, and all the ARC members. And as Dr. Sikdar always used to say, we are co-conspirators. But we debated, we had so many differences of opinion. But what made it so very special was at the very end, we always reached a consensus. When the National FP 2020 Action Plan used to be developed annually, we always had a consensus. So that's what made it very, very special. I truly find the theme of the summit for today very apt for the National Family Planning Program. Sabka Saath, Sabka Vishwas, Sabka Prayas and Sabka Vikas. Having worked very closely with the Ministry, all technical and policy divisions, and especially with Dr. Sikdar and his stellar rockstar family planning team, I can state on record that the National Family Planning Program has definitely translated this vision into practice. The agenda and the diverse stakeholders who have assembled here today, if you look at the range of civil society organizations, development partners, professional medical associations, healthcare providers, young people, we have program managers from the states, policy makers. I think that itself is a reflection of the spirit of partnership and commitment of everyone to support the National Family Planning Program. For all of us working on this common agenda, this event today offers an opportunity to comprehensively review the progress, but also chart the way forward. And I assure you that I will use the 10 minutes that have been allotted to me very judiciously. So the organizers were worried. They thought I am going to narrate the 70-year partnership of USAID with the FP program. So I'll just restrict for the 10-year journey. In the first 5 minutes, I'll just talk about the few highlights of the 10-year journey and then also lay out certain priorities for the future. So in 2012, when the global FP 2020 movement was launched, all eyes were in India, and rightly so, because if the global goals were to be achieved, the ambitious goals, then India had to deliver. So in India, even prior to the summit, there was a very unique grassroots civil society led organizations which had all come together to even shape the agenda for the London summit. After that, this was followed by an unprecedented exercise of data driven and evidence based action plans, wherein each district of the country developed a very detailed action plan, taking care of the local context, the demand supply challenges, the local stakeholders, and the data was at the core of it. So Martin Smith is over here with us today, and he can attest to the fact that the district level action planning that was done was definitely a template that even other countries were very curious to know about how that national plan was translated into district level action. These evidence-based action plans which were done at the district level, and also the National Family Planning 2020 action plan that was done on an annual basis with the support of all partner organizations, really set the tone of the journey for the last 10 years, and which was again furthered by several new initiatives that were launched by the government, and the progress is there, the results are there for everyone to see. At USAID, we feel that we are indeed very, very fortunate that we had the opportunity to support the National Family Planning Program and several states through a range of our projects and implementing partner organizations, and also working in close collaboration with the FP 2020 core group, UNFPA, Gates Foundation, Packard Foundation, and other civil society organizations. I would just briefly highlight top 5 highlights of a 10-year journey. The first and foremost is the focus on evidence and data for decision making. We supported the various rounds of the National Family Health Survey that remains the gold standard for data on fertility and demographics. And to add further value, we launched the unique Rasta initiative to use the NFHS data to conduct secondary research to support the family planning program by addressing the bottlenecks and even coming with actionable items. This initiative has resulted in more and more young Indian professionals getting engaged in the family planning agenda, and also strengthening the regional institutions, local Indian regional institutions, for conducting high quality family planning research which can only benefit the policies and programs in years to come. The second one is on the expansion of contraceptive options in the country. Whether it was injectable contraception or progesterone only pills or Centroman, USAID has been a partner to the ministry when it has come to expanding the basket of contraceptions in country, and we continue to work closely with all the other development partners to identify further opportunities to expand the basket. The third area is private sector engagement. This has been an important part of our strategy, and through our projects we have demonstrated several newer approaches, whether it is digital technology solutions or workplace interventions, PPP models, unique partnerships such as the Condom Alliance or even an SRH helpline. We have recently launched UDAN, a collaborative that brings together various private sector partners to increase access to SRH information, products and services by young people and address the market inefficiencies for family planning. The fourth one is the focus on younger cohort of population. This was a conscious choice. Bearing in mind the changing demographic, we, through our programming, tried to ensure that adolescents and young people are empowered to make appropriate SRH choices. We were a proud partner of the 10 to 19 Adolescent Collaborative, which involved multiple funding agencies and cross-sectoral programming to holistically address SRH, the felt needs of adolescents, ranging from education, livelihoods, life skills, agency, and of course SRH. We even supported a youth survey on what do young people want, and have recently launched a youth-focused campaign, Baatein Unlocked, that engages young people in conversations around their health and well-being. Last but not the least is the emphasis on integrated programming and partnerships. As part of the ministry's integrated RMNCHA program, we were able to focus on enhancing the uptake of voluntary family planning products and services, using the continuum of care and life cycle approach across all the higher priority districts that were assigned to USAID as lead development partner. This effort continues through the Ayushman Bharat Health and Wellness Center program, the Aspirational Districts Initiative, the RKSK program, the School and Health and Wellness Initiative, and all these initiatives actually involve partnerships across all levels of the healthcare delivery ecosystem and also with all the partner organizations. A lot of progress has been made in the country in terms of FP indicators, and I'll not delve deep into the data or the various initiatives, that this has already been addressed by the previous speakers. I'd just like to highlight the fact that if the upward trajectory must be maintained and universal coverage of reproductive health services in India has to indeed become a reality, then a lot more needs to be done. The COVID-19 pandemic has exposed several fault lines in the healthcare delivery system. It has challenged several fundamental assumptions on health-seeking behavior and even on how healthcare should be provisioned. However, it has opened several new opportunities as well. So newer partnerships coming to the fore, a very unique spirit of collectivism, community action, the importance of self-care, direct-to-consumer channels. In addition, the Government of India has launched several integrated healthcare initiatives which have been matched by significant budgetary allocations, whether it is the 15th Finance Commission or PM Abhim. There is strong political will also to transform the health sector and so on and so forth. So the opportunities are immense. It is imperative on all of us now on how we capitalize on these opportunities and identify newer approaches to address the unmet need of contraception in the country and truly make it a 21st century program. Taking a closer look at the successes and challenges reveals that on one hand there has been a substantial increase in eligible couples in need of contraception from 66 to 76%. However, the actual demand satisfied shows only marginal improvement from 72% to 74%. There are nearly 50 million eligible couples that are still in need of modern contraception. How do we ensure that our national program is able to cater to their needs and bridge the gap? There are several such questions. How do we ensure that we are able to address the geographic inequities? How do we ensure that our programs are tailor-made, looking into the specific context of even reaching out to the northeastern states? How do we ensure that with the increased urbanization that is happening, how does our program gear up to cater to the needs of the urban poor? How do we ensure that we reduce the demographic inequities or the gender inequities as well? For USAID, inclusive development remains at the core of our programming. We constantly strive to ensure that our programs reach out to the most vulnerable populations. We have launched several key initiatives that address issues of child early and forced marriages, teenage pregnancies, and gender-based violence. As India moves forward with a new vision of attaining universal health coverage, there is a need to build on the existing evidence, just catalyze fresh ideas and work collectively. I would just like to end, 8 seconds. I would just like to end by committing on behalf of USAID, हमारा साथ, हमारा विश्वास, हमारा प्रयास और देश का विकास, which we truly believe will enable India to showcase its learnings to the world and become a global leader. Thank you all for patient hearing.
Thank you, Amit, and thanks for the slogan coming from Amit Shah, Dr. Amit Shah. So this is very timely slogan. And I don't want to reel out all the things that you said, because as you said, we are co-conspirators or partners in crime, and we've been doing things together in the arena of adolescents, self-care and everything. And in the interest of time, I'll quickly move on to our next speaker, which will be Dr. Rajni Ved, who will represent the Gates Foundation over here. Over to you, Rajni, please.
Good afternoon, everybody. An awkward time in two ways. One, before lunch and a guest, and two, following speakers who've actually covered a lot of ground. Okay. Is that better? Thank you. So being here today, not just in the midst of you all, the launch of the FP 2030 work in India, but also celebrating 70 years of the launch of India's family planning program is a matter of pride and honor, and the foundation is glad to be part of this summit. But I think, although India was one of the first countries in the world, as has been repeated over and over again, to launch a national family planning program, over the decades, population studies scholars and scholars of family planning programs in India, despite highlighting certain aspects of the program, have commended again and again the intent and design of India's family planning program as being reflective of a genuine desire and high level of political commitment to actually improve living standards of women and a focus on women's health. Over the years, the family planning program has evolved to reflect subnational needs, expand choices, access availability, and integrating a standalone vertical program into a primary healthcare system. These have not been small achievements. When Dr. Sikdar made his presentation, and I remarked to him that that presentation reflects not just India's success, but I think for many people, both at the national and at the state level, often a culmination of their lifetime's work on family planning. And so India's successes of family planning are also very much reflected in the personal and professional lives of people at the sub-district, district and national levels. The health system strengthening efforts over the last decade and earlier have enabled India's family planning program to leverage significant investments. Now, these investments initially spanned infrastructure needs. They enabled improvements in financing, and this is not just a matter of adding additional resources, but enabling creative investments at district and sub-district levels, both in forms of incentives as well as in forms of additional budgets, expanding the numbers and the capability of human resources. Phrases such as task sharing and task shifting, which we often use very often for human resources for health development, actually started in family planning, both with community level workers as well as sub-center level workers. India has more than met the progressive commitments made to FP 2020, as you all heard this morning, in terms of expanding method choices, financial commitments, a focus on client-centric approaches, strengthening quality, enabling accountable private sector engagement. And again, I say, having come from work on primary healthcare approaches, that the family planning program actually has a lot to offer, and we need to both exchange lessons on how family planning, despite being launched as a vertical program, has still enabled substantial health sector reforms, including legal and regulatory reforms. So the strengthening of quality and finally ensuring equity. And I think Mission Parivar Vikas in its most recent avatar is really a great emphasis on ensuring equity in the family planning program. The foundation is indeed privileged to partner with the Ministry of Health and Family Welfare and applauds the commitment in scaling up multiple innovations across the country to particularly benefit last mile populations. Now, what does a partnership for contraception in the 21st century from development partners really means? I think it means that we co-develop strategies to address the changing needs of India's population. Speakers before me have said how the demography has changed, how epidemiology has changed, socio-cultural demography, the digital revolution that's currently sweeping across the country. So going forward, our strategies must take into account these very changes. And this is not necessary just to sustain the momentum that we've achieved, but also to make sure that we actually enable the goals of FP 2030 to be met. The Bill and Melinda Gates Foundation has a long history of supporting health programs, but family planning is earmarked as a priority issue. The foundation recently committed $280 million per year globally for the decade spanning 2021 to 2030 to support family planning programs in keeping with the preferences of local communities and enabling women and girls to be in control of their contraceptive choices, if, where, when, and to that end, support the development of innovative and improved contraceptive technologies. In addition to being particularly engaged in India, Ethiopia, and Nigeria, where the foundation works in close partnership with national and subnational governments, the foundation also supports programs in other countries to invest in global and regional platforms such as FP 2030 for continued prioritization of family planning. In India, the BMGF works closely with the Ministry of Health and Family Welfare at the national levels and in the states of Uttar Pradesh and Bihar. And you've heard enough too that UP and Bihar, including Maharashtra and West Bengal, are really key to our achieving family planning goals. The FP 2030 commitments of GOI, with a focus on hard-to-reach geographies and populations, and expanding the reach and range of contraceptives, intend to introduce methods are very encouraging. At the Foundation, we look forward to working with the Ministry. The findings of NFHS 5 actually, while in many ways extremely encouraging, such as increasing uptake of reversible methods, particularly with the introduction of Chaya and Antara, a plateauing of permanent methods, and Dr. Sigdar told us, increasing birth intervals, but the rise of traditional methods. These are all a validation as well as a flag that new approaches and new methods are needed to address the needs and aspirations, particularly of India's younger cohorts. It is against a backdrop of these changes, increasing trends towards urbanization, and its BMGF reiterates its commitment to the Government of India. So we continue to support the Government of India at the national level and in UP and Bihar, and for the following few areas, which I will quickly articulate. This includes not just support for supply and demand for interventions alongside the introduction of newer methods, but the use of behavioral insights and digital approaches, both new methods in which to understand more closely how and why young people will use methods and how we can use digital technology appropriately to make sure they get appropriate counseling and appropriate information. Second, we work to converge women's health and women's economic opportunities, both of which are critical for greater impact, and our early pilots in Bihar demonstrate that working through women's self-help groups could actually be an important pathway for male engagement. Third, we leverage the health and wellness centers and India's move towards comprehensive primary health care to support the primary health care team, and you saw the launch of the module for the community health officers. We use the opportunity because women and girls are accessing the health and wellness centers in larger numbers to use this as an opportunity to promote family planning methods and improve the quality and access. Finally, the Foundation commits to supporting pilots, producing the required research and evidence needed to inform scale-up across not just our particular geographies, but across the rest of India. The Gates Foundation will continue to provide strategic and catalytic support to help the Ministry achieve its 2020 goals with a strong focus on voluntary participation and quality. Thank you all very much.
Thank you, Rajni. Very much appreciate for the time. No denying the fact that Gates Foundation has been one of our strongest partners over the last 10 years and continuing to support family planning, and really want to put it on record, the support that Gates Foundation gives us for different arenas or aspects of family planning. So thank you very much for all the areas of support that you've reeled out in the national level as well as at the state level. And in the interest of time now, I request Anand Sinha from the Packard Foundation to give his brief talk on the support for the FP 2030 and whatever thoughts that he have other than that. Over to you, Anand.
Thank you so much, Dr. Sikdar. It's quite a wonderful event today, and there's just a glowing sense of pride, and I'm wondering where the sense of pride is coming from. The sense of pride is coming from the fact that we have achieved something that is significant and many of us thought was potentially insurmountable 10 years ago. It's coming from having everyone together after not having everyone together for many years and having come through a very dark period in our history. And I think it's again, the message that we've heard from everyone is very, very clear, is that we have come a long way. We have made progress, and we have come a long way that we should be proud of. And at this point in time, I'm having images of, Dr. Sikdar being Edmund Hillary, sitting on top of Everest, sort of having scaled these heights and these peaks, and wondering which peaks to go to next, right? Because that is, I think, the challenge ahead of us right now, is once you've scaled what you think is one of these, great challenges that needs to be done for the welfare of the country, where do we go next? And again, I think the vision document lays that out perfectly. There is actually very little for us to be talking about. There is a lot for us to be reading in that vision document, because the vision document does contain pretty much everything that everyone is saying here. I'm just going to try and highlight 2 or 3 of those points in that. I think one is, the title of today is Sabka Saath, Sabka Vishwas, Sabka Prayas, Sabka Vikas. That's great. There's one word that's repeated in there 4 times, Sabka. It's not kuch logon ka, it's not jyada logon ka, it's not most people, it is Sabka, right? And I think that's very clearly outlined in our vision document. We are all about inclusion. We are all about diversity. We're all about equity. The focus on figuring out who's getting left behind, that is the next peak, or one of those next peaks that we need to figure out. Who is getting left behind? Is it the young people? Is it migrants? Is it people from disabilities who have disabilities? Is it people from LGBTQI communities? Who's getting left behind in these services, and how do we cater to and overcome the barriers that we have faced so far in trying to address those groups? The second peak that we will need, and this relates to the point about Sabka Vikas, is everyone's talking about youth and adolescence. And youth and adolescence is such a huge part of the next peak that we need to climb. But we need to think about them not only as the recipients and as the people who will help us get to our targets, but we need to really think about what does it mean to hand over leadership and be inclusive about them. Again, the vision document outlines this very, very clearly. Okay? I'm very proud to say that one of the announcements some of you would have heard yesterday is that the Advocating Reproductive Choices Coalition, ARC, is recently transitioning the secretariat function to the YP Foundation. I was lucky to be part of the advisory group that was sort of thinking about this transition. And one of the things behind that decision was to say, if we are so concerned about young people, we can't just be giving them a seat at the table. We can't just be thinking of them as beneficiaries or as recipients. We actually have to let them take control. We actually have to think about what it means. And why is that important? It is important because the innovation, the energy, the boldness, the fearlessness, and also because of the political legitimacy that young people have in today's environment to be able to make significant changes. If young people ask for changes, we listen. Society listens. Decision makers listen. It's important to put them in the driving seat. The other thing that's important to recognize is that technology is changing faster than we have imagined. The lines that have blurred adolescent health, contraception, family planning, abortion are all getting blurred. The decisions that are taken by women as to when and where and how they want to have babies and how they don't want to have babies are becoming blurred. We're seeing this every day now, whether it's thinking about, am I going to plan 6 months in advance? Am I going to plan years in advance? Am I going to plan a day in advance? Am I going to plan the next day, 3 days later, 2 weeks later, 2 months later? It's part of a continuum of decisions that people are taking. And technology, whether it's thinking about emergency contraception, whether it's thinking about medication abortion, whether it's thinking about the new upcoming contraceptive technologies, is going to blur that. And that's going to force us to have to work together. We will not be able to separate women's lives into neat little boxes that says that this happens at this point in time and this happens at another point in time. And again, the vision document lays that out very clearly. We're thinking about how to be more inclusive. How do we work with maternal health? How do we work with HIV? How do we work with the different parts within that health continuum to lay this out? The Packard Foundation has been a partner for the reproductive health program in India for more than 21 years. We are very proud of what we have achieved. I'm always surprised, and thank you, Dr. Sikdar, for inviting me and allowing me to speak here. I'm always surprised when I'm asked to come and attend and speak at these events, because I feel that we're not a very visible and a very present partner. We tend to stay somewhere in the background, but I think we support our partners, civil society partners, the experts, with great fierceness and with a great deal of freedom to sort of do what they think is right. And I'm just here to emphasize that again. We are here to stay. We're here for the foreseeable future. We will continue to provide that support to our partners so that they in turn can provide the support needed to the government of India and to the people of India to continue this program as we seek and peak those new heights with the leadership of the government, and hopefully with the leadership of Dr. Sikdar as well. Thank you so much.
Thank you, Anand. I think you mentioned that you just work at the background. I think you are a silent sort of a partner, and sometimes silent partners are actually very, very productive as far as the government is concerned. So thank you for all the support that you've been giving all these years, indirectly through the partners. And we actually get those partners, whomever you grant, to get the work done for the government. So it's actually, you are actually supporting the government indirectly. So I think I'll not summarize this because we are actually behind 20 minutes as per the schedule. Only thing is that thanks to all my panelists who have really given their come out with their thoughts about the support that they are talking about for going forward into FP 2030, and very glad to hear that they will continue their support, and as in a spirit of partnership, we will work all together to achieve the goals that we have set out for ourselves in the vision document. With this, we have one piece of work left in the morning session. Unfortunately, we could not award two of our awardees from the states. There was a little bit of glitch. We want to rectify that because they have to catch a train back to their states. So Mandeep, over to you to please do that particular thing, and we can award it from the dais or we come ahead.
Thank you, Dr. Sikdar. We would, of course, prefer that you join us center stage and forward. Yes. I'll request all of you to please join us center stage and forward. And I'll request the awardees to please join us as I call their name. In nurses category, for PPIUCD, please put your hands together for the first winner, Ms. Rajkumari from Aurangabad, Bihar. Second one goes out to Ms. Raksha Jain, Udaipur, Rajasthan. Thank you, Dr. Sikdar. Thank you, esteemed panelists, for doing us the honors of presenting these two awards. May I request you to please join us back in your seats. And once again, our heartiest congratulations to all the winners. It's no mean feat, not an easy achievement. So once again, heartfelt thanks and congratulations to you all. And now we would like to thank our esteemed panelists for their participation in this session. As a token of our thanks, we present to them these green plants. Again, a piece of Mother Nature going out to all of them as a token of our appreciation and thanks. We thank Dr. Sikdar, Ms. Andrea Voynar. Our thanks to Dr. Sikdar, Mr. Martin Smith, Dr. Sikdar, for taking us through with this session. Thank you so much. And the rest of the esteemed panelists. We'd like to thank Dr. Amit Shah, our thanks to Dr. Rajni Vaid, our thanks to Dr. Anand Sinha, once again a heartfelt thanks for a session well conducted. And that concludes our first session, which was entitled Who, What, Where and When, Understanding Current and Evolving Trends for Contraception. With that, we take a break for lunch. I'm sure it's very good news, but please do remember that we once again congregate and we are going to start the next session sharp at 1:50. So please do not be behind time. We would like to start the next session on time. Thank you and enjoy the break. Executive Director of the Population Foundation of India and has over 40 years been a strong advocate for women's health, reproductive and sexual rights, and rural livelihoods. She has co-conceived the popular trans-media initiative, मैं कुछ भी कर सकती हूँ. That is, as a woman, I can achieve anything. And before joining PFI, she served as the India Country Director of the John D. and Catherine T. MacArthur Foundation for 15 years, and also co-founded and led the Ashoka Foundation, Dastakar, and the Society for Rural, Urban and Tribal Initiative, that is Shruti. She is an alumni of Delhi University and Harvard University's John F. Kennedy School of Government, She serves on the governing council of several non-governmental organizations and is a regular commentator in India and globally for television and the print media. So, ladies and gentlemen, once again, I'll request you all to please kindly take your seats. As you can see, the esteemed chair and the esteemed panelists have already joined us on stage. We are ready. So, if I could request you all to please quickly get back to your seats.
Please, can we request everyone to settle down? There's going to be lots of opportunity to talk to each other. There's a lot to talk about. But in the meantime, for the panelists to be given their fair time, may I request everyone to settle in?
I'll now request the session chair, Ms. Mutreta, to please take us forward in this session.
Good afternoon, everybody. Can I hear a good afternoon? Can we also settle down, those of us who still are looking for our places? I have a great panel with me, as you can see here, so we do want to listen to them and give them their full time. So we've had a wonderful morning, and it is no more news that India is doing very well. India has stabilized its population. India has thought a lot about those who've been left behind, the women in the most marginalized communities, adolescents, those who are in remote parts of India, and the vision document is a great document for this panel to have behind us, having released and identified the 8 important areas that the government is going to go forward in working on, and Sabka Saath, Sabka Vikas, Sabka Prayas, or Sabka Vishwas. I'm not saying it in order, but Sabka is what this panel is going to highlight. And I'm going to start with a great champion of adolescents in the ministry, as well as somebody who works very closely with many of us, Dr. Zoya Ali Rizwi, who, as you all know, has not only championed the cause of adolescents, but has also been a long-time fellow traveler in the field of reproductive health and women's health. She has vast experience in working not only in the government sector at the national level, but also the state level. She's a gold medalist from King George Medical College in Lucknow and the London School of Health, Hygiene and Tropical Medicine. Over to you, Zoya. Zoya has a presentation, and Zoya, you have the responsibility given to you to ensure Sabka Saath.
I press it. Okay, yeah. Good afternoon, everybody. I have the, I think, pleasure and honor of addressing so many people coming from various states, from development partners, our implementing partners also. So welcome, and I hope I'm able to put my point across about the importance of adolescent health in the whole gamut of family planning services. I will just start by saying what is inclusive SRH. I know all of you know, but just to reiterate that being adolescent itself is a vulnerability. So any health system and community which supports the most vulnerable of the people, which includes the adolescent, the people with disabilities, people living with HIV, LGBTQIA+, prison populations, everything, they should have access to sexual reproductive health services. And especially I want to point out is what is the adequate attention which is often neglected in the components of sexual reproductive health when we talk, of course, is first and most important is appropriate and non-judgmental services. I speak with the lens of adolescent health, so please take it from that. Access to safe, non-judgmental services is a very big issue for adolescents who are accessing services, whether family planning or others. There are a lot of issues of unplanned pregnancy, so access to safe and legal abortion services, access to safe menstrual hygiene services, prevention, detection, counseling on gender-based violence issues faced by adolescents, sexual and infertility treatment also, many sexual adolescents also face that. And lastly and most important is the access to information regarding the sexual reproductive health issues. So why do we want to add adolescent? All of you have been through adolescence and are like now healthy, fit adults. But all of us have been through these very common factors, which is whether it is onset of menstruation, whether it is contraceptive needs, whether it is onset of sexual activity, the huge physical, psychological, sexual, behavioral changes which take place. There may be unplanned sexual activity leading to unplanned pregnancy and not lack of access to abortions. Then there also is the change in mentality from adolescent to adulthood. So these are all issues which all of us have faced, and that is why we need to put adolescent right there in any health component. Just briefly to let you know what are the basic status of SRH services, all of you are very well aware that still as per the NFHS 5, still about 23% of girls are married before 18 years, 7% of girls do become pregnant before the age of 18, 20% of currently married women are actually having access to contraceptive methods. 18% of them still face unmet family planning needs. So family planning is a word which we use for contraception. So yes, at least 18% do not have access to contraceptive services. And last one is very interesting. You see the median age for onset of sexual activity as reported is about 18.9 for girls and 24.8 for boys. This, as an adolescent health proponent, I would say this is something which we don't really believe in, because a lot of evidence shows that activity starts much earlier than that, but this is what the data says. And the two good things which have come in SRH for adolescent is the access to safe menstrual hygiene practices, which has gone a huge from about 57% to about 78% over the last 5 years. So that awareness is in place. And second, of course, is the knowledge about any modern method of contraception that has really increased to about 95 and 96% in male and female. So response to adolescent health in India, of course, you are very well aware, we moved from the clinic-based services, which was in adolescent reproductive sexual health ARSH program, to the Rashtriya Kishore Swasthya Karyakram, in which we moved from the clinic-based to find the adolescents where they are. So they are in schools, they are in the communities, they may come to clinics. So this program looks at the 6 thematic areas, which is improvement in SRH, improvement in nutrition, prevention of NCDs, prevention of substance misuse, prevention of injuries and violence, and also improving mental health. So 3 main strategic interventions which we have in RKSK, Rashtriya Kishore Swasthya Karyakram. Again, I mentioned from services in the clinics, we move to the communities and school. So in clinics, we already have existing what we call adolescent-friendly health clinics. We have about 7,200 odd in India across all states. And we are developing what we call a model AFHC at district level to ensure excellent quality of adolescent services. Second, we have the school-based, all of you must be aware of the WIFS, the weekly iron supplementation program, which happens through school, through teacher distribution. Then we have the sanitary napkin distribution in schools. And we also have the annual checkup of all school children annually under the Rashtriya Bal Swasthya Karyakram. And of course, now the TD vaccine also has started for 10 and 16-year-old. So school intervention. Now we have the community-based, which many of you may know about the peer educator component. Then we have the Adolescent Health and Wellness Days, a huge, huge opportunity for us to catch hold of stakeholders and talk about adolescent health. And just to share with you, last year we celebrated more than 1.45 lakh Adolescent Health and Wellness Days across India. So that is the kind of ownership which we are getting from states as to the importance of adolescent health. These are the various packages, just to let you know, in the adolescent-friendly health clinics, not to enumerate, but just to let you know that in the SRH, so we have all the thematic areas, but in SRH, these are the main services which we are providing, and about 40 lakh male and
important. So please, less noise from the cutlery and crockery. Thank you.
Okay, yeah, no. So just to say, what does inclusive vision for adolescent program look like? First is there should be a clear roadmap which includes SRH issues of every adolescent comprehensively. Let us not just do tokenism. We have to address the SRH issues which are faced by adolescent in the road mapping of 2030. And the approach for access to SRH services should be comprehensive and grounded in accessibility. This is something which is very important, which we stress on. Any service for accessible, affordable, non-judgmental, non-biased. So that is some issue. And of course, there should be tailored strategies for the hard-to-reach populations, whether they are marginalized, underserved, so that every SRH prepared all activities, these marginalized populations also have access. And all of you are very well aware, we have certain set of people who don't really access services, whether they are residing in the tribal area, in the slums, whether they are gender non-conformative. So all these various issues should be addressed by our SRH values. And of course, finally is addressing the essential health. We should also see that the economic barriers, the social barriers which these young adolescents face, they should be addressed comprehensively whenever you're looking at creation of an inclusive vision which includes the adolescents. So what needs to be done? First is we require systemic changes at various levels. I would say is building capacity, even though it's number 3, building capacity of the key stakeholders. They should be made aware that adolescent health is really, really important. Even though adolescents don't really fall ill, you need to put equal amount of money in adolescents as you put in maternal, as you put in child, as you put in immunization. Right now has to be healthy, there'll be healthy adults, and in the future if they want to be parents, there'll be healthy parents who will rear healthy children. So investment in adolescent is very important, and that's how you need to build the capacity of stakeholders. The community don't bring about a behavior change, you'll reach nowhere. So involvement of community in adolescent health is very important. And of course, correct information has to be shared whenever any kind of transaction with the stakeholders. That is very important. Second, of course, we have to understand what are the barriers our young people are facing when they access services. So understanding will help us plan. We have to also have inclusive outreach activities and not be stuck in, say, school and facilities. We should also look at outreach activities so that no one is left behind. Fourth, of course, is male involvement. So much of our SRH interventions just targets women, but we have to bring the boys, I would say the male component, way back right to the front. So we have to look how we will add males so that they become equal partners of any SRH intervention. Next, of course, is that if there are SRH interventions, whatever programs are already implementing, say we have RBSK, Rashtriya Bal Swasthya Karyakram, we have school health and wellness, like I mentioned, so they should already include SRH so that we don't have vertical programs being run in the schools, in the communities, in the various states. And of course, most important is quality. Like I keep stressing, the quality of services which we give the adolescent decides whether that adolescent comes back to us or he goes somewhere else. So quality is very important for us. And of course, we have to encourage non-threatening focused discussions in communities so that every adolescent feels safe. They can talk to their parents, their teachers, and the healthcare providers. What is the outcome which we are looking at? First is, of course, that it will reach out to the most underserved. Adolescents who already are privileged are anyway having services. So the ones who don't have access, who don't have information, who don't have the money, who don't have the knowledge, that is especially, of course, for less than 20, that is our program. Second is this should lead to an increase in demand of SRS services. The data 8 lakh girls, this data, more and more questions are always there in adolescent mind, so they need to come and ask. So that SRS services should increase. We know the benefits of prevention of RTI. This will lead to an overall improvement in health of all women. That is something which is important. So we will have decrease in cases of any kind of complications of bad reproductive health, cancers, HIVs. That is there. And of course, if women are healthy, we will have a higher productive force. So then there will be to say that any inclusive vision which contributes for improvement of women and children will anyway decrease the risk of anemia, survival rate. So we're looking at a healthier population. And finally, of course, any improvement in health for all. If we have good health young adults, we will of course have much better economic growth and of course less inequality also. I think a lot of inclusiveness is here. Thank you.
Thank you for saying so much in so little time. Clearly, you've taken us beyond only providing SRH services for young people and identified almost a roadmap where we need to do more to retain and bring in young people. That's a big challenge, and with you there, I'm sure it'll happen and you'll walk the talk. Now I'm going to move to Aparajita. Dr. Aparajita Gogoi is a person who has lots of experience at the grassroots level as well as advocacy mobilizing. You'll all remember that 2 decades ago, Aparajita led the White Ribbon Alliance, so there is no better, and we all trusted her and joined her. At the government, NGOs, so I can't think of a better person talking about Sabka Vishwas, which is the subject of your, which is your focus today. Aparajita has as you all know, is the Executive Director of Center for Catalyzing Change. She has a PhD in International Politics from Jawaharlal Nehru University, and Aparajita's track record, we all know of successes and a leader in the SRH field. So over to you to win over everybody's vishwas in what you say.
Thank you, Poonam, so much, and thank you to the Ministry for giving me an opportunity to talk about how to engage communities. I know that the topic given to me is Sabka Vishwas, pooling strength and strengthening commitment towards universal RH. We've been given 10 minutes, so I have taken an executive decision just to talk about community engagement, and I hope Dr. Sigdar is going to forgive and agree. forgive me and agree to this. I want to talk about how important it is today to embed community engagement in our plans, our policies, and in our effort to achieve universal health care. We have evidence, our work tells us that if we want to reach marginalized groups, if we want to really reach people who are at the margins of the system, community engagement is one way to reach the last mile. However, I also want to say that community engagement doesn't really happen by itself. If we want community engagement to work, we have to design, we have to implement, and most importantly, we have to invest, both in terms of investing in systems and investing in communities about how this interface can happen. But one thing I am sure of, that if we can make community engagement integral to our efforts to achieve universal health care or universal reproductive health, we will see a big change. We will see that health is not just a transaction between the provider and the receiver, but this will be a movement where we can see that health and well-being are co-owned, co-designed, and taken together by system and the communities. And in this process, we will see the empowerment of both the providers and the communities. Today, we are, of course, talking about our gains around family planning. But I also want to re-emphasize the fact that if we are talking of reproductive rights like family planning, we know that until and unless we address social norms, it will be very, very difficult to reach our ultimate goal. We know, even if you look at NFHS 5 data, there are still pockets in our country where son preference is impacting family planning choices. We know that there are pockets in the country where child marriage is high. And if we do not address social norms, we will be kind of somewhere halfway, or rather, if we want to reach our target, we have to look at in urban areas, you have the Jan Arogya Samitis, you have Rogi Kalyan Samitis, Mahila Arogya Samitis, we have ASHA volunteers are scheme. And I think if we invest in some of these community structures and community people who are change agents in the community, I'm sure that we can stimulate meaningful community engagement. When we talk of engaging community, engaging women, we cannot not talk of the efforts that we have to do to really increase women's choice. I think that we have done pretty well in integrating community perspectives, but I think we have to do more so that women have the autonomy to make a choice, to act on a choice, and to voice this choice. And engaging communities can, really help us build this bridge which connects women's voices to program implementers, intermediaries, policymakers, etc. And I want to briefly refer to the What Women Want campaign, where we spoke to about 3.5 lakh women across India, and we just asked them one question: what is it that you want when you talk of reproductive health care? And as you can see, women from across the India spoke about what they needed. In 10 minutes, I can to talk about another model of engaging with communities. C3 has been working for the last 15 years of figuring out how do we work through elected Panchayati Raj members in order to have impact on the ground. Our model really is to build a cadre of PRI members who can act as key influencers, who can champion and support women's health and women's rights. We work mainly with women elected leaders, with young grassroots leaders who are in their constituency. We build the capacities so that they can function as vocal leaders, as social advocates who are talking of reproductive health and rights, who are talking of maternal health, who are talking of Mission Parivar Vikas, what it entails, and also engages with the system and the provider at the front line. We started off as a demonstration project way back in maybe 16 years back, but today we are very, very happy to report that in states like Bihar, for example, we are doing this work at scale. We are training mukhyas of all 38 districts, and I have to acknowledge the support that we have received from the state health department, the state PRI department, MOHFW here, and of course the Packard Foundation and the BMGF, the Bill Gates Foundation, who's really supported us in figuring out how do you implement a model which is practical, which is scalable in order to work with PRI members on the ground. I do have a small film which I am trying to fit in my 10 minutes, so I'm not going to cover all of this, but as you can see, these are pictures of how PRI members are supporting MPV activities in Saas Bahu, Beti Sanmilans, distribution of the Nai Pahal kits, having a special Mahila Sabha before the Gram Sabha so that family planning appears in the agenda of the Gram Sabha. Before I go to my film, I do have one last point. I think COVID really told us that in order to reach the last mile, it is really, really important that you work with CSOs and NGOs. I know that today that's kind of a little difficult to talk in a completely plain vanilla kind of a way, but we know that NGOs and CSOs who work on women's empowerment can engage directly at the last mile, but we need to invest resources and invest trust in the CSOs and NGOs for community engagement. At the same time, I think we also have to invest in ensuring that we are training our health providers so that they can also imbibe an institutional culture of engaging with communities. We may have programs, but if we do not support health providers also to engage with communities, we will not see the final outcome of community engagement. With this, thank you again so much, and I'm going to ask for your help in playing a very small film, which I think Poonam is going to fit into my time. Thank you so much for your patient hearing.
मैं पहली बार अपने क्षेत्र की जनता के सहयोग से पंचायत चुनाव जीत कर आई हूँ। परिवार नियोजन मुद्दा जितना सुनने में सरल है, उतना वास्तव में ये हमारे लिए चुनौतीपूर्ण एवं महत्वपूर्ण है। इसकी जानकारी हमें C3 संस्था के द्वारा 2 दिवसीय आयोजित प्रशिक्षण में मिला। प्रशिक्षण के दौरान ही हमने ये गांठ बांध लिया था कि परिवार नियोजन मुद्दा पर ही मुझे विशेष रूप से कार्य करना है। वार्ड में अपने वार्ड सभा का आयोजन किया, जिसमें आंगनबाड़ी दीदी, आशा, ANM को भी बुलाया। इसमें हम अपने उदाहरण देते हुए, इस बैठक में अपना उदाहरण देते हुए बताया कि किस तरह से हमारे द्वारा परिवार नियोजन नहीं कर पाने के कारण हमको बहुत ही परेशानियों का सामना करना पड़ रहा है। मेरा परिवार बहुत लंबा हो गया है। इस तरह से बताने पर कुछ हमारे समुदाय के लोग खुलकर आए और अपनी बात एवं समस्याओं को साझा किए। आंगनबाड़ी के दिन, आरोग्य दिवस के दिन विभिन्न संसाधनों को हम लोग इस्तेमाल करने के लिए दंपति को बताते हैं, जैसे कंडोम, मालाएं, छाया की गोली, अंतरा सुई, कपरटी और दंपति के बच्चों के अनुसार अस्थायी संसाधन को भी बताते हैं, जैसे बंध्याकरण, महिला बंध्याकरण, पुरुष नसबंदी के बारे में भी पुरुष लोग को जानकारी देते हैं। सास बहू का भी बैठक हम लोग अपने वार्ड में कराते हैं, जिसमें पति पत्नी के अलावा सास भी रहती हैं, ताकि उनको भी जानकारी हो सके कि किस तरह से हम लोग अपना परिवार नियोजन करके अच्छा से रहेंगे। और इस मुद्दे पर बात करने के लिए मौका देने के लिए तथा मेरे अनुभवों को सुनने के लिए आप सभी को बहुत बहुत धन्यवाद।
Thank you, Aparajita, for expanding how we can work with communities. And clearly, after the 15th Finance Commission, working with panchayats has become now not only an imperative but very important for us to scale up the great work that Aparajita has done in Bihar and other places, working with panchayats on SRH issues. And we have much to learn from you, and these teasers in 10 minutes are not enough either to hear about the lessons and how we can work with Panchayat Raj institutions or what women had to say. I always listen to you spending 2 sentences on that. We really need 10 minutes next time to listen to you, Aparajita. Thank you very much, and thanks for also highlighting that for community engagement, the role of CSOs and NGOs is very important. So from Aparajita, we go to Dr. Shanta Kumari, who, as you all know, is the president of FOXY. Dr. Shanta Kumari is a senior consultant gynecologist, obstetrician, and a specialist in laparoscopy surgery. I should mention she's the 60th president of FOXY, and we are very privileged to have you with us. With 2 decades of experience on both academic work and patient care and social service. We will learn much from you. Earlier we heard involvement of the private sector is very important, and given that FOXY members work across the country and work on SRH issues beyond only contraception, we'll learn much from you on how Sabka Prayas matters, especially the private sector.
Thank you, Dr. Poonam. I would like to thank and congratulate Dr. Sigdar and the whole team. It's definitely Sabka Prayas which has made this possible for everyone to be here, and I bring greetings from FOXY, the 38,000 strong body of OB-GYNs, and FIGO, the global voice of women. This year, the theme has been FOXY for all, always, and Dhira, stop violence against women. When you look at the vision and mission of FOXY, FOXY stands for all women, with Dhira to say no to violence against women, for every mother to reduce the maternal mortality rate to reach the SDG goals, for every FOXYan to be able to practice with safety, dignity, and protocols. Women's challenges are many at a global scale, and we OB-GYNs are committed to take care of our women because we are the first point of contact to any woman for any issue. Why is it that you need to involve FOXY? Because we are a network of more than 38,000 members with 262 societies across India and highly dedicated professionals, the FOXYans. When you look at FOXY's focus on SRH, advocating the cause of reproductive and sexual health and rights is a part of the mission statement of FOXY. We have got a lot of subcommittees with 3 focused: family welfare, MTP, and public awareness, which focuses on issues of SRH. And from time to time, FOXY actually issues policy statements on SRH issues. Because there is a huge spectrum of unmet needs which needs to be understood, and my OB-GYNs are the ones who are taking care at the grassroots level, be it addressing the adolescents, the youth, the unmarried, the sexually diverse residents of inaccessible areas, and sometimes even to tribal communities. When you look at some of the policy statements over the years, 2003 saw us come out with a statement on medical methods of abortion to injectable contraceptions, population stabilization, emergency contraception, then the low-dose hormonal oral contraceptive pills, expanding the provider base for safe abortion, be it the female condom, the contraceptive implants, the non-scalpel vasectomy, to the late abortions, post-abortal contraception, postpartum IUD, the progestin-only pill, providing a safe base for safe abortion services, and no to violence against women. We work as the advocacy with the Ministry of the Health and Family Welfare, the Government of India, And with other partners, we disseminate the global update on the SRH, sensitizing our medical community and public awareness, leveraging the digital technology in reach. Now, what have been the achievements so far? We have been able to be a part of the policy changes regarding the expansion of the contraceptive baskets, including many new drugs, and the MTP Amendment Act, which we have to congratulate our government for coming out with. A lot of publications of FOXY and SRH. We have sessions in the annual congresses at the national level. We have Best Society prizes for work done on population stabilization and constant partnership with NGOs who are working in this domain. We are aware that RH outcomes are related to adherence of human reproductive rights. We understand that we have to see the women have the right to confidentiality, dignity, comfort, continuity, and opinion. Because reproductive rights are nothing but human rights. Sabka Prayas definitely is partnership with all and every partner, be it the FIGO, the WHO India, the UNICEF, the USAID, the RCPI, the RCOG, the NNF, the IAP, the ICMR, NIN, and so many others IMA. This is what is the most important aspect of the success of any program if you're talking about women's health. We started off with many programs. The last year, when after taking over as the president, we had the World Population Stabilization Day. We have seen the incredible times of the COVID where the online media has actually made us come together from the domain of the homes. And we could actually take this World Population Stabilization Day in association with the WHO India across our country. We had more than 5,000 participants. And we had Dr. Sigdar who had addressed us with the WHO India and so many other partners. Many of you on board here were a part of this program. Youth Day was very important as an advocacy because unless you touch the youth, you cannot make a difference. And involving them with the UNICEF was our important achievement. And have a bit of a celebrity to catch them, to catch their attention was what we did. The FOXY Contraception Day program was a hybrid program at Mumbai, where we had with us online Dr. Ashok Babu, who joined us in this collaborative effort. Dhira. Dhira means courage. It's an initiative which I started in 2015 to say no to violence against women. When I became a member of FIGO working group, and I have to put on record that we in India, women are more empowered than in any other part of the world. And we have to actually thank our government and everyone for many of the issues. But when it comes to the reality, we sometimes find that violence definitely affects a woman's health. A woman has a right to decide her sexual and reproductive rights, and we are here to offer her that. So this Dhira, No to Violence Against Women, was a 5-pronged approach. We started the Pillar 1, which is the online school certification program in coordination with the UNICEF India. This program has been going on very successfully. We have covered more than 250 schools till date, lot of online programs, and now we have actually moved to the physical offline school programs. And you should hear the comments made by the boys and the girls, because I don't want any boy to grow up, if he has seen his father or anybody do violence, he should not grow up thinking it's okay to do violence. Neither should a girl grow up thinking it's okay to accept. We need to move into a more gender-neutral society. And that is where you can actually say the sexual and reproductive rights of the women are actually upheld. The obstetricians are involved. We can definitely make a revolution by involving everyone right from the beginning. Respectful abortion care, a FOXY and WHO initiative. I again reiterate that we Indian women are very lucky. 1971, we had the MTP Act. When to date, in 2022, unfortunately, countries have criminalized abortion. Imagine a doctor, a gynecologist being booked for offering safe abortion to a woman. It's something which is not acceptable. And I would really like to thank on behalf of Foxy and all the women of the country, our government, our partners, for giving women this power of sexual and reproductive right, which is the way forward. We are the leaders to show the world how to take care of women's health. This program is going very well, and I have to tell you all, there are other global societies. As the treasurer of FIGO, we interact with the other societies, and there are there are all the advanced countries, but when it comes to women's rights, they're absolutely not. We and I can be a leader to those, and that is the most important idea. We're going to take this project across the borders of India because women across the world need our help. This has been a beautiful program, and definitely we find that there are a high number of child brides in our part of the world, and Foxy, we undertake regular awareness programs in schools to enlighten these things right from the beginning, and that will go a long way. We can definitely bring in male participation because private sector has got good rapport with the male members of women's families. I would like to reiterate that when you say Sabka Prayas, you need to involve each and every person in the country, not only the public sector, all the private sector, because unless everyone partners together, we will not be able to achieve what is best for the women of our country. And that's exactly what I think this program is all about. So thank you very much for being with us, and Foxy always stands by taking care of women's health, which is a priority. Thank you.
Thank you, Dr. Shanta Kumari, a leader of 38,000 members with so much passion, and thanks for sharing with us the work Foxy does beyond the private sector, for the public, for policy, for advocacy. And you know, we worked very closely in ARC with Foxy when Antara was introduced in India, and I can tell you all that the technical and advocacy both role that Foxy played did contribute to introducing a new contraceptive to India. May I now move to Dr. Niranjan Sagurti. He's, as you know, the country director of Population Council of India. Niranjan has a PhD from IIPS, our very own IIPS, which gives us the NFHS data, and with students like Niranjan, we now understand how well they are able to do, giving us not just good news, but giving us data through the years, through NFHS, as well as many other much more research. So Niranjan for the last 2 years has been engaged with research on SRHR, earlier with BMGF and now at Pop Council, and we've all learnt a lot from how he has analyzed the data from NFHS from different point of views. But today Niranjan is going to talk to us about the demographic, both transition as well as the dividend, and go on to talk about other people who will be engaged in taking us forward for the Vikas. His subject is Sabka Vikas. Kariye.
Thank you so much, Poonam, for that kind introduction. Thank you, Ministry, for giving me the opportunity to speak on Sabka Vikas, optimal utilization of the demographic transition. For a change, I thought I'm not going to use these slides, but going to talk a lot about the numbers. The numbers that we all need to keep in mind, because the demographic transition is a consequence of the family planning program, the years of family planning program. And today we all heard from different panelists how and what else do we need to do to strengthen the family planning program going forward, and FP 2030 vision document has beautifully outlined the strategies and given a lot of data and input into it. What I am going to talk is on the other side. that how the family planning program and the demographic transition that India has achieved is actually going to help country make a progress. So let me place that argument in a while. As a demographer and a data cruncher, as Poonam said, we are happy to witness that India reached the replacement level fertility, which is a significant milestone in India's demographic history. The decline is spread evenly across the country, with all 29 states and union territories having TFR of even 1.9 or less, and 7 states or union territories with TFR below 1.6. All southern states have a TFR of 1.7 to 1.8, similar to Sweden. So now we kind of compete with many of the developed countries, many of our states. Even those states which have not reached the replacement level fertility are in that direction, headed in that direction. On the one hand, this replacement level of fertility is telling success story of the long-standing family planning program in the country. On the other hand, this is also placing the country in a demographic transition stage where population is likely to be stabilized for the next couple of decades owing to the variation in fertility decline across geographies. We saw some of the data that Sanjay presented on the other day on World Population Day event where he spoke about how the different states are reaching, having that huge demographic transition and the demographic dividend at various time points, and which was very interesting. So one of the features of this initiation of population stabilization is the increase of that broad base of younger population, which the country has started already witnessing. According to an estimate, the country has one of the youngest populations in the world, in the era of aging world across many developed countries. In 2020, the median age in India was just 28 compared to 37 in China and the US and 45 in Western Europe and 49 in Japan. Furthermore, our country growth of the working age population will be larger than the population below age 14 years and above 65 years. This bulge of the working age population is likely to last till 2055 with a peak that we will reach by 2041, which suggests that how this demographic transition that India has achieved with a successful family planning is actually going to re-up and translate that into the economic advantage. And to give you some statistics in that regard, India will add 183 million working age group population in the 3 decades between 2020 and 2050. And the maximum that working age population is getting added during the 2020-30 years. And I'll come to the point why I'm quoting these statistics in a moment. And then additional 61 million, which is going to be added in 2030-40, that period, and 21 million in 2040-50. So as we move in the next 3 decades in time, with the working age population, the addition is going to go down. So which suggests that we are at a stage when there is a whole lot of advantage as a result of this demographic dividend. And evidence showed that the demographic dividend will be at peak around 2041 when the share of working age population is expected to hit 59%. And that time it will be 22% of the global workforce is actually going to be in India. And post 2050, that's when India will start experiencing the decline in workforce. So what this all means, why do we need to know these numbers in terms of the population and what way it is linked to the sexual and reproductive health and the family planning and family welfare in totality? Is because if we take care of the population of this volume at this time, that's when we are actually going to see the benefits, not just from the health perspective, but also on the larger developmental aspect. So we have several progressive policies in the country at the moment. You name it, whether you take the skill development mission, which has the goal of upskilling 500 million people in India by 2022, and the new national education policy to introduce synchronized with modern industry demands and learning levels in academics, startup and make in India, and Atmanirbhar Bharat, encouraging the private entrepreneurship and ease of doing business. All these policies are in right direction to reap the benefits of the demographic transition. India is fortunate that its demographic transition is phased because as the demographic dividend, we all heard a lot in many places, and even this morning some of the panelists were talking about how the India is at an advantageous position in comparison to several other countries. But within India, the demographic dividend is going to last for a more extended period due to that regional variation in the onset of the fertility decline and the time at which the fertility is going to reach the replacement level. Southern states, for example, which are advanced in demographic transition, already have a higher percentage of older people. These differences in age structure reflect the differences in economic development and health, which reminds us that the states' different starting points for achieving the 2030 SDG goals. This also offers boundless opportunities for states to work together, especially on demographic transition with the North Central region as the reservoir of India's workforce. As southern states struggle with the growing burden of supporting the elderly, northern states will support the workforce needed for economic growth in the country for a longer period of time. The increasing pace of migration may help shore up economic expansion in the south from workers from the other states. So there is that whole issue of the migration, and I'm happy to see in FP 2030 there was a discussion about how the migration and the family planning is connected and is going to be the future vision in the document. And the ways to optimal use of the demographic transition, we all have seen how the countries like Singapore, Taiwan, and South Korea have already shown us how the demographic dividend can be reaped to achieve incredible economic growth by adopting forward-looking policies and programs, and we have right policies in place at the moment. There are important lessons from these countries in order to operationalize the implementation of those policies. And I have a 3 points to make. The first is that given that India's workforce starts at a very younger age, a greater focus needs to be on the transitioning from secondary education to universal skilling and entrepreneurship. That is going to be the primary focus, and that needs to happen in order to get the advantage of that demographic transition that we have witnessed. The other second point is utilizing the progress we made to ensure universal access to quality reproductive health services. We saw from many presentations today that the adolescents, young people, continues to have the unmet need for contraception. But if you look at the data over time, the unmet need for contraception, even for that young population group, has reduced substantially, even from NFHS 4 to 5, which in NFHS 3, when the unmet need for contraception was almost 50% for the married adolescents, has been reduced to 20s in 2021, which is a substantial progress. What we need is further continuing our effort and the intensity in order to keep pace with the required needs and services of the young population to make sure that we are achieving the universal access. And at the same time, let me also say that the focus should continue to remain on the generating more data, especially on the adolescents and young people, because we need to know a lot, not just from the health perspective, but also from the overall developmental perspective. And that needs to be continue to be the focus. Lastly, the optimal utilization of demographic transition is incomplete without increasing the female work participation in the economy. As of 2019, 20.3% of women were working or looking for work. New skills and opportunities for women and girls benefiting their participation in a $3 trillion economy is urgently needed. For example, a girl who passes class 10 needs more choices to learn skills that will help her and find appropriate work. Finding work will likely not only delay the age at marriage, but also make her participate in the economy more productively, as also exercise her rights and choices. When we talk about the Sabka Vikas, it is more about the people and their choices and the rights. And I propose to end this talk by saying Sabka Vikas is possible with Sabka Saath, Sabka Vishwas, and Sabka Prayas. And all sectors, not just the family planning, is not the only responsibility of the family planning division of the Ministry of Health and Family Welfare, but how the young population and the working population is interlinked with various other sectors, and everybody has to put their effort and prayas into making a successful Sabka Vikas. Thank you.
Thank you, Niranjan, and thank you for reiterating and giving us evidence and reminding us once again that Vikas development is the best contraceptive and good for young people, women, and everybody. Thanks also for sharing with us that not only did our demographic transition happen in phases in different states, but demographic, we assume dividend is also going to happen, but it could happen in phases. It means we have longer time, but the investments you have suggested is something clearly which has to be part of our 2030 vision. I was told we have 20 minutes for Q&A. Do we still have 20 minutes for Q&A even though we ate into our lunch? No, we have no time for Q&A. Okay, so we've been given 2 questions. And who would like to ask one of the 2 questions? Is it lunch or is it the clarity of the panelists? Okay, so with that then, did I see a hand? No. So I am going to take that as lunch. One hand. Please go ahead, do introduce yourself, and if you can keep the question or comment really short, we are short of time, as you know.
Hello. Hello.
We can hear you.
I'm Dr. Yamini Sarwal, presently the family planning in charge of Safdarjung Hospital. So I would like to know when we are expected to get the progesterone only pills and the implants in our basket of choices.
Great, short, quick, and very, very important question. Somebody from the government has to answer that. Is Dr. Sikdar here? Dr. Sikdar, you're being marked. He's there. He'll never be marked absent, not when it comes to family planning. Dr. Sikdar, please answer that question.
Could you repeat? I didn't hear the question. I was talking something else. Sorry.
Sorry. When will implants be introduced is what Dr. Sarwal asked. I promise you, Dr. Sikdar, I did not ask that question.
Okay.
And progesterone pill. She also asked that.
Yes, ma'am.
Please, everybody, participant, be witness that Dr. Sikdar is going to think I asked this question and I didn't.
So, very simple and straight answer is this. Implant will come when its time will come. As simple as that.
No, we all knew Dr. Sikdar had become a great demographer, not only technocrat, administrator, everything. Today he's proven he's become a diplomat too.
It's very difficult to handle my friends like Poonam unless and until you are a diplomat. Okay.
Is there anybody from from non-government or a partner who might want to also add to what Dr. Sikdar has said on when will implants come? Koi nahi bolega. किसी की हिम्मत नहीं है डॉक्टर सिकदर, मैं सेशन बंद कर रही हूँ. All right,
Yeah,
guys.
I think, yeah.
Thank you very much. Thank you to the. Let's give a big hand to our panel. And I want to really thank the Dr. Sikdar and the Ministry of Health and Family Welfare for having a panel which is a great panel. There are three women on the panel and one man, and I'm moderator. Okay, 4 women and 1 man on the panel. Normally, in most departments and webinars, we see more men than women, and I'm very happy to have this kind of balance, so thank you very much. We had great presentations, and we hope that we will not take more time and that some of the vision that has been shared by the panelists will become part of the vision going forward for FP 2030. So I will not repeat what they have said so that we can hear from the next panel. Thank you very much.
Ma'am, I'll request you all to please remain with us on stage for just a minute more. We would like to thank you, express our thanks and gratitude. We would like to present these green plants to you as a token of our appreciation and thanks. Thank you, Dr. Gogoi. Thank you, Dr. Rizwi. Our thanks to Ms. Poonam Mutreja, ma'am. Thank you for chairing the session. Our thanks to Dr. Santa Kumari. And our thanks to Mr. Niranjan Sagurthi. And yes, a minute more for Mr. Photographer, who was very disappointed earlier that he was not getting his photo op. So let's not deny him his photo opportunity. Thank you, esteemed panelists, for this session. It was a very enthralling discussion. Thank you. And I promise you the next session is even more enthralling because we have voices from the youth. So as you can see, I'm sure some of you have spotted them already. We have some young representatives, and they are young public health representatives. We have Ms. Keka Shah, then we have young public health representative, Mr. Suraj Kant, and we will also be talking and hearing from engaging men for family planning. This will be the topic that Dr. Mohammed Yaqub Pasha will be talking about. We've already met him earlier in the day when he was receiving his award. And talking about providing community level services would be Ms. Vinam Lovanshi. She is Asha, District Hoshangabad, Madhya Pradesh. So very quickly, if we could hear the voices from the young representatives, would you? So ladies and gentlemen, it gives me great pleasure to invite them all to please join us on stage. And this session is being moderated by Dr. Ratnamala Desai, President, Family Planning Association of India, and Ms. Keka Shah, Mr. Suraj Kant, Dr. Mohammed Yaqub Pasha, and Ms. Vinam Lovanshi. May I request them all to please join us on stage. I would now request Session Chair to please take the session forward.
Good afternoon, ladies and gentlemen. Welcome to this postprandial session. I am Dr. Ratnamala Desai. I am the National President of Family Planning Association of India. I am very happy here to moderate this session on voices of the nation and leaders of impact. As we all know, India was the first country to launch a national program of family planning in 1952, and the program has undergone a massive metamorphosis from its early days, where the focus was mainly on female sterilization. Now we've moved on to the focus on reproductive health. Now each one of us is a unique strand in the intricate web of life, and each one of us is here to make a contribution. The character of a whole society is a cumulative result of the countless small actions, day in and day out, millions of people perform. Small changes that seem insignificant in isolation can be great contribution when they are simultaneously undertaken by many of us. Here we are with 4 participants, 4 of my very young panelists, who are the voices of the nation, who have contributed in their own way in the collective upliftment of the health of the nation and have become leaders. At the outset, I have 2 youth here. Youth are the present and the future. Let me ask Ms. Kaishkasha to introduce herself first and let me know how she got interested in public health. This is a time for you to go for movies and parties, but now you're in public health. Please share your views. You can go there or speak from here. I will. Yeah.
हेलो, आवाज़ आ रही सबको? ऐसे कर दीजिए, वहाँ से नहीं आई आवाज़. हेलो, मैं बोलूँगी हेलो, आपको बोलना हाय. हेलो, हेलो, एक और बार. हेलो. यस, थैंक यू सो मच. गुड आफ्टरनून एवरीवन. मेरा नाम कहकशा है और मैं 22 साल की एक युवा कार्यकर्ता हूँ जो दिल्ली में रहती है और मैं व्यापक यौनिकता शिक्षा पे काम करती हूँ. और सबसे पहले मैं आज के ऑर्गेनाइजर्स को धन्यवाद कहना चाहूँगी युवाओं को इसमें सम्मिलित करने के लिए, क्योंकि अक्सर जब युवाओं की बातें होती है तो उनको भागीदारी नहीं दी जाती है. तो थैंक यू सो मच, मैं आपकी आभारी हूँ और मैं पूरी कोशिश करूँगी कि मैं युवाओं की ज़रूरतों, उनकी चाहतों को यहाँ पे सबके सामने रख पाऊँ. तो जैसे कि आप सब जानते हैं कि इन सब पर बातें करना, जैसे कि गर्भधारण, गर्भ निरोधन और परिवार नियोजन के बारे में बात करना इतना आसान नहीं है, खासकर एक युवा होकर, क्योंकि हम लोगों तक जानकारी पहुंच पाना बहुत मुश्किल काम है. तो इस जानकारी को प्राप्त करने के लिए हर किशोर और युवाओं का अनुभव और चुनौतियां भी अलग अलग होती है, क्योंकि हमारी पहचानें अलग अलग हैं. हम जिस पृष्ठभूमि से आ रहे हैं, जिस बैकग्राउंड से आ रहे हैं, वो सब अलग अलग है. जब मैं 19 साल की थी तब मैंने पहली बार वाईपी के साथ जुड़कर व्यापक यौनिकता शिक्षा का कार्यक्रम शुरू किया, जिसका नाम था शरीर अपना अधिकार अपना. पहले शुरू में बहुत झिझक महसूस हुई, शर्म का मुद्दा है, इतने खुल के बात नहीं की जाती. फिर मेरे को समझ में आया कि फिर मुझे लगा कि मैं अपने माँ बाप को कैसे बताऊंगी मैं किस मुद्दे पे काम करती हूँ. क्या मुझे लोग सुनेंगे? क्या मुझे सही जानकारी मिलेगी? क्या मेरे सवालों की गोपनीयता बनाए रखी जाएगी? क्या जो मैं पूछ रही हूँ वो ज़रूरी समझा जाएगा? ये सारे सवालों के साथ मैंने अपने सफ़र को शुरू किया. अभी मुझे वाईपी में काम करते हुए 6 साल हो गए और 6 साल के इस मुद्दे से मुझे इतना समझ में आया है कि गर्भ निरोधन, गर्भ समापन एक ऐसा मुद्दा है जो कि सबकी बेसिक ज़रूरत है, हर सिटीज़न का राइट है और ये सबको मिलना चाहिए. ताकि हम लोग, क्योंकि हम ही आगे के जनरेशन है, सब ये बोलते हैं कि आप युवा हो, आप आगे सत्ता चलाओगे. सॉरी, मेरी साड़ी मुझे बहुत डिस्टर्ब कर रही है. हाँ, ठीक है. तो अपनी ज़िंदगी की यौनिकता के बारे में और इसके बारे में जानकारी होना ज़रूरी है ताकि हम सही फैसले ले सकें। तो एक प्रतिभागी से जो ट्रेनर बनने की मेरी जर्नी है वो इतनी आसान नहीं थी, बहुत सारे कठिनाइयों का सामना करना पड़ा। और लेकिन 2 मिनट में दिल से बात करना चाहूँगी आप लोगों से कि एक नागरिक होने के नाते और एक सिटीज़न होने के नाते मुझे लगता है कि गर्भ निरोधक के बारे में हर किसी को जानकारी होना ज़रूरी। अगर आप जानकारी दोगे तभी वो अपने अधिकारों को उपयोग में ला पाएंगे, वो संविधान तक ही नहीं रह जाएंगे। आज मैं दिल्ली, यूपी और बिहार में किशोर किशोरियों और युवाओं के साथ यौन और प्रजनन स्वास्थ्य पर अधिकार और न्याय की ट्रेनिंग देती हूँ। हम देश में आज भी किशोर किशोरियों को अपनी शादी के निर्णय लेने की इजाज़त नहीं है। अपने सहमति से बनाए यौनिक रिश्ते के भी बहुत कम जगह युवाओं को मिलती है। ऐसे में अपने प्रजनन से जुड़े निर्णय लेना बहुत मुश्किल है, चाहे वो शादी से जुड़े हो या नहीं। मैं हमारे कार्यक्रम के माध्यम से समाज में युवाओं और उनके घर वालों के साथ शादी करने के अधिकार, प्रजनन के निर्णय लेने के एजेंसी पर संवाद करती हूँ और आज लगभग 30,000 किशोर किशोरियों के साथ हम ट्रेनिंग ले चुके हैं। गर्भ निरोधक और समापन, उनकी प्राप्ति और सही उपयोग की जानकारी भी किशोर और युवाओं के साथ सहज करती हूँ। लेकिन आप सभी भी जानते हो कि एक युवा होने के नाते ये जानकारी देना और लेना बहुत मुश्किल काम है। इसलिए मैं किशोर किशोरियों के साथ सत्र चलाते समय सबसे पहले उनको सुरक्षित महसूस कराती हूँ, उनको एम्पैथी महसूस कराती हूँ कि उनकी बात सुना और उनके मुद्दे बहुत ज़रूरी है। वो ऐसे नहीं है जो सिर्फ एज में छोटे हैं, लेकिन उनकी ज़रूरतें बहुत महत्वपूर्ण हैं और उनके नज़रिए और उनकी गोपनीयता बनाए रखने के लिए मैं उनको आश्वासन देती हूँ। तो इस तरीके से एक सेफ, सुरक्षित जगह बनाने की कोशिश करती हूँ अपने सत्रों में। मेरे अनुभव में अगर हम किशोर और युवाओं से बात करते हुए उन्हें एक समान पद पर रखते हुए उनकी कहानियों और अनुभवों को अपने कार्य में और ढांचे में सबसे महत्वपूर्ण स्थान देंगे ना, तो हम सफल ज़रूर होंगे जिस काम के लिए हम निकले। जब मैंने पहले सत्र में काम करना शुरू किया था तब मुझे बहुत ही जल्द समझ आ गया था कि हम इन सत्रों में बगैर जजमेंटल हुए, बिना किसी भेदभाव के उन मुद्दों से जुड़ेंगे जो किशोरों को और किशोरियों और युवाओं को महत्वपूर्ण रखते हैं। हम उस मंजिल तक पहुंच पाएंगे। आज मैं बहुत गर्व महसूस करती हूँ कि मुझे इस काम को करने का अवसर मिला है। मैं चाहती हूँ कि हर गांव और बस्ती में मेरे जैसे ही युवाओं को गर्भ निरोधक को लेकर सही और सटीक जानकारी मिले। इसी संदर्भ में मैं आदरणीय गेस्ट को कुछ सुझाव साझा करना चाहूँगी युवाओं की आवाज़ के रूप में। पहला, अगर हम युवाओं से संबंधित कोई भी नीति बना रहे हैं तो हमें उसके हर स्तर पर युवाओं को जोड़ना चाहिए, उनके सलाह मशवरों को सीरियसली लेना चाहिए। हम युवा ज़रूर हैं बट हमें अपनी ज़रूरतें बहुत अच्छे से पता है। दूसरा, फैमिली प्लानिंग के कार्यक्रम करने वाले कार्यकर्ताओं को उनको सेंसिटाइज करना चाहिए ताकि वो युवाओं के प्रति समान अनुभूति रख सकें, उनके बैकग्राउंड, उनकी पहचानों के साथ संवेदनशील हो। तीसरा, व्यापक यौनिकता शिक्षा के बारे में हर स्कूल में हमें कार्यक्रम चलाना चाहिए, वो भी सरकार को एनजीओ के साथ मिलकर, जहाँ पे युवा कार्यकर्ताओं की भागीदारी बहुत, क्योंकि युवाओं की नीड्स को युवा ज़्यादा बेहतर तरीके से बता पाएंगे। चौथा, सामुदायिक और स्कूल से बाहरी स्तर पर हमें सुरक्षित जगह बनाने की बहुत ज़रूरत है, जहाँ पे युवा अपने ये सवाल के पिटारों को लेकर जा सके, ये सोचकर कि कोई ना कोई उनके जवाब देंगे। पांचवा, सुरक्षित यौन संबंध की इस जागरूकता के सफ़र में हमें पेरेंट्स को जोड़ना बहुत ज़रूरी है, क्योंकि सबसे ज़्यादा उनको पता होना चाहिए कि उनके बच्चों की क्या ज़रूरत है और क्या चाहत है। मैं अब इस मिशन में किशोर और किशोरियों को उनके यौन और प्रजनन स्वास्थ्य से संबंधित अधिकारों के बारे में जागरूक करती रहूँगी। बस आखिरी में इतना बोलना चाहूँगी, I want to ensure equal access to contraceptive and abortion to all the citizens of India, regardless of their caste, creed, class, gender identity, religion, or any other social identifying factor that usually block their access. Thank you very much for listening, a youth.
Thank you so much, Kekasha. I like your energy and enthusiasm, and you are the voice of the youth. And you have put up very clearly what are the demands of the youth. After seeing you, I have become very optimistic about our nation, really. Okay? Thank you. Now we go on to another youth, Mr. Suraj Kant, please.
आते ही प्राउड से स्वागत हुआ, थैंक यू। मुझे यहाँ पे आमंत्रित करने के लिए सबका शुक्रिया। जब एक युवा होके इतने सारे लोगों के बीच अपनी बात को रखता है तो एक प्राउड फील होता है, और ये मौका देना युवाओं के लिए इतने लोगों के सामने बोलना एक बहुत बड़ी बात है। मैं आप सभी लोगों का धन्यवाद करता हूं कि मुझे ये मौका मिला। मेरा नाम सूरज कांत है और मैं वाईपी संस्था के साथ मिलके पिछले 3 सालों से प्रजनन स्वास्थ्य के ऊपर काम करता हूं। मैं एक ऐसे समाज से आता हूं जहां पे जब हमारे टाइम हमारे घरों में कॉन्डम्स के ऐड चलते थे तो पिताजी या माताजी उसको टीवी को बंद कर देती थी या फिर उस ऐड को हटा देती थी। मेरी तरह ये बहुत सारे युवाओं या यहाँ पे बैठे बहुत सारे लोगों के साथ ये हुआ होगा। मैं उस समाज से आया हूँ जहाँ पे जब हम सरकारी स्कूल में हम अपने 10th के साइंस का चैप्टर पढ़ते थे तो जो हमारे मास्टर, जो हमारे गुरुजी होते थे, वो खुल के उन बातों को बता नहीं पाते थे। तो अब आप सोचिए कि अगर ये मेरे साथ हुआ है तो मेरे साथ बहुत सारे युवाओं के साथ ये सेम चीज हुई है। जब हम अपने समुदाय में युवाओं के साथ, किशोरों के साथ काम करते हैं तो हम बहुत करीब से उन चीजों को जान पाते हैं। जो युवाओं के प्रजनन स्वास्थ्य के मुद्दे हैं उसको हम बहुत आसानी से अनदेखा कर देते हैं और हम बताते भी नहीं है। जब एक युवा या एक किशोर किशोरी अपने प्रजनन स्वास्थ्य के बारे में जानना चाहती है तो हम उनको बोलते हैं ये तुम्हारा मुद्दा नहीं है, शादी के बाद तुम्हें अपने आप समझ आ जाएगा। जब हमारी शादी भी हो जाती है और शादी के बाद हम जानने के इच्छुक होते हैं तो हमें बताया जाता है ये तुम्हारा मुद्दा नहीं, तुम्हारी बीवी का मुद्दा है, ये महिला का मुद्दा है, वो अपने आप देख लेंगी। तो हम लोग एक दौर से इन सभी मुद्दों को एक महिला मुद्दा बताते आए हैं और हम एक जो पुरुष है वो अपनी सारी भागीदारी महिलाओं को देते आया है। हमने हमेशा बच्चे पैदा करने का मुद्दा महिला का माना है, गर्भ निरोध इस्तेमाल करने का मुद्दा महिलाओं का माना है और पुरुष की भागीदारी हमेशा हमने इसमें पीछे रखी है। आज जब हम अपने समाज में काम करते हैं, जब हम उन्हें सही समय पे बच्चे पैदा करना, शादी करना, अपने पार्टनर को समझने के बारे में बताते हैं तो ये इतना हमारे लिए आसान नहीं होता किसी भी युवा और किशोर के लिए, क्योंकि एक मिथ शुरू से चलता आ रहा है हमारे लिए जहां पे ये बताया जाता है कि शादी होते ही आपको एक बच्चा पैदा करना है। अगर आपने बच्चा नहीं पैदा किया तो गांव वाले बोलेंगे हाँ तुम्हारे में कुछ खोट तो नहीं है। और ये एक ऐसा स्ट्रॉन्ग मिथ है जो बहुत तेजी से फैल गया है। मतलब शायद मैं यहाँ पे उन अनुभवों की बात कर रहा हूँ जिसको हमने बहुत करीब से जाना है। एक महिला पे बहुत अलग अलग तरीके से कमेंट होता है कि आप जाके चेकअप करवाइए क्योंकि अभी तक आपने बच्चा नहीं किया। जब हम ऐसे समाज के साथ काम करते हैं बहुत मुश्किल होता है एक बड़े मिथ को तोड़ना जो सालों से चलता आ रहा है। हमारी बहुत सारी कोशिश होती है कि हम ऐसे मुद्दों पे काम कर पाए, हम ऐसे मिथ को तोड़ पाए। जब हम अपने समुदाय में काम करते हैं हम हमेशा एक गतिविधि का इस्तेमाल करते हैं जिसका नाम फोरम थिएटर है। हम फोरम थिएटर के जरिए जब हम किशोर किशोरियों या यूथ को उनके मुद्दे को उठा के सामने रखते हैं, उनके परिवार के सामने रखते हैं तो हम एक संवाद बनाने की कोशिश करते हैं जहां पे हम ये सोचने पे मजबूर करते हैं कि ये मुद्दा सिर्फ महिलाओं का नहीं है, सिर्फ लड़कियों का नहीं है, इसमें पुरुष की भी भागीदारी है जिसको हमें समझना चाहिए। मैं अपनी बात लास्ट पॉइंट करके खत्म करना चाहता हूं कि पता नहीं क्यों मैंने ये बहुत करीब से फील किया है कि जब भी हम हेल्थ की बात करते हैं जब भी हम गर्भ निरोध की बात करते हैं, जब भी हम कॉन्डम्स की बात करते हैं, तो ये सभी मुद्दे पता नहीं क्यों हम सिर्फ एक जेंडर पे थोप देते हैं या सिर्फ महिला के ऊपर वो जिम्मेदारी रख देते हैं। आज भी हमने देखा है कि जब भी हमारे समुदाय में कोई ऐसा हेल्थ का प्रोग्राम चलता है, वहां पे पुरुषों की संख्या बहुत कम होती है, महिलाओं की संख्या बहुत होती है। एक झिझक ये भी है कि जब हम एक सहज कर्मी होकर काम करते हैं, एक हेल्थ कर्मी होकर काम करते हैं, तो हम खुद उन सभी प्रजनन स्वास्थ्य के मुद्दे पे बोलने से टकराते हैं जो किशोर और यूथ भी करते हैं। कई सहजकर्मी या कई ऐसे साथी हैं जो कॉन्डम या उनके प्रजनन स्वास्थ्य से रिलेटेड कुछ भी बात बोलते हैं तो वो खुद एक सहज जाते हैं और बहुत बारीकी से उसको रखने की कोशिश करते हैं। अगर हम सभी भी ये करते रहेंगे तो हम कैसे बहुत जल्दी जो हमारा फैमिली प्लानिंग का सपना है उसको पूरा कर पाएंगे। हम सभी को जरूरत है कि हम इसमें पुरुष की भागीदारी को बहुत अच्छे से सुनिश्चित कर पाएं, हम उनको अनदेखा ना करें, हम ऐसे प्लान बनाएं जहां पे वो भी इसमें शामिल हो। और प्रजनन स्वास्थ्य हमारा अधिकार है, सिर्फ स्वास्थ्य एक मुद्दा नहीं है। थैंक यू।
Thank you very much, Mr. Suraj. You have stressed about the importance of awareness of sexual and reproductive health, not only for women, but also for men and young boys. Thank you so much. Next on the panel, we have Dr. Yaqub Pasha from Telangana. We have all seen him receiving an award this morning. And he has been working in the government sector. He has joined government service in 1998. And he's been working in various capacities and is currently working as Deputy DMHO. He started doing vasectomy in 1998, and to this date, he has done over 40,000 no-scalpel vasectomies. He has received 5 state awards and the Best State NSV Surgeon Award. Dr. Pasha, it is appreciable that you have worked a lot on male involvement in family planning. You must have faced many challenges. Please let us know about your good work.
Good afternoon to all stakeholders of different states and union territories. I thank S.K. Sigdar sir for inviting me to talk few things on National Family Planning Summit. So, gender inequality rooted in cultural norms with male-dominant society, lack of male involvement continues to cause poor family planning procedure nationwide. So, we need to remember that family planning is not just a woman's issue, it is a couple's issue. According to NFHS 5, male sterilization in India is 0.3%, as it is same in NFHS 4. Male sterilization in Telangana is 1.6%, and male sterilization in Warangal urban district, where I am working, now it is a district Hanamkonda of Telangana state, it is 11.2%. So, though vasectomy is safer, quicker and easier option, Indian men do not undergo this procedure as they are worried about myths like losing their virility and cannot perform hard works after the procedure. We are conducting group meetings with eligible couples at panchayats and municipal wards with MOs, supervisors, ANMs and ASHAs, inviting men from same locality who adopted vasectomy to remove the myths like loss of virility, doing hard works like previous. For example, Hamalis who lift daily 50 to 100 kgs of weight in markets and godowns. So after procedure, they are conducting 1 week after procedure, they are conducting same procedure. Same thing, taddy tappers who climb taddy trees regularly 1 week after the procedure. In our district, men accepting the male sterilization irrespective of literacy, whether living in urban or rural areas. The public health system, family planning procedures, communication strategies should be designed to encourage male engagement. Social media platform to be used in innovative way. For example, satisfied clients' interviews can be used to motivate others. Selecting brand ambassadors like Amitabh Bachchan ji for promoting male sterilization may improve like other national health programs. The failure rate is very minimal, that is 0.002% among surgeries done in my career. More number of general surgeons and medical officers should be trained in no scalpel vasectomy surgery, which will benefit to conduct more camps. Ours is male-dominant society, and in all aspects, men try to come forward. Then why they are not coming forward for male sterilization? This should be debated among men eligible couples to protect female health and in turn the family, society and nation. Thank you. Jai Hind.
Thank you very much. Your service to the nation is appreciable. But I disagree with you, not Amitabh Bachchan. Maybe Ranveer Singh or Ranveer Singh should be used for advertisement of NSV.
Thank you,
and
madam.
Last on the panel, but not the least, I welcome Srimati Vinam Lowanshi. She's an ASHA worker from Itarsi, Madhya Pradesh. आपने कोविड में बहुत अच्छा काम किया है, एंड जब सारे लोग घर में बैठे थे, आप काम कर रहे थे, आपने बहुत मुश्किलें झेल ली हैं. आप हमारे साथ थोड़ा शेयर कीजिए कि आपका काम के वास्ते में हमें बताइए.
आप सभी महानुभावों को मेरा नमस्कार. मैं विनम लोवंशी, शहरी आशा कार्यकर्ता, न्यास कॉलोनी, वार्ड 12, जुग्गी, इटारसी, ब्लॉक केसला, जिला नर्मदापुरम, मध्य प्रदेश से 7 वर्षों से लगातार कार्य कर रही हूँ. मेरे मन में हमेशा से लोगों की सेवा और मदद करने की इच्छा थी, जो कि आशा कार्यकर्ता बनकर पूरी हुई. हम सभी आशा कार्यकर्ता राष्ट्रीय स्वास्थ्य मिशन की महत्वपूर्ण कड़ी है और स्वास्थ्य योजनाओं को लोगों तक पहुंचाने का महत्वपूर्ण कार्य कर रही हैं. राष्ट्रीय स्वास्थ्य मिशन के प्रमुख लक्ष्य मातृ मृत्यु दर को कम करना और शिशु मृत्यु दर को कम करना, सकल प्रजनन दर को कम करने के लिए निरंतर प्रयासरत हैं. कोविड काल के दौरान जब आपातकाल की स्थिति थी और हम सभी अपने घर में कैद हो रहे थे, तब भी आशा कार्यकर्ताएं घर घर पहुंचकर अपनी सेवाओं को सुचारू रूप से चला रही थी. कोविड काल के दौरान लॉकडाउन के कारण लोगों को जरूरी चीज़ें भी उपलब्ध नहीं हो पा रही थी. उस समय घर घर तक स्वास्थ्य सेवाओं को पहुंचाने का कार्य हम आशाओं ने किया. लॉकडाउन के समय हमारे शहर इटारसी, जो रेलवे का बड़ा जंक्शन है, बाहर से भी लोगों का निरंतर आगमन जारी रहा. उन तक स्वास्थ्य सेवाओं को पहुंचाना एक चुनौतीपूर्ण कार्य था. कोविड के समय इटारसी शहर में इतना ज़्यादा संक्रमण फैल रहा था, जिससे लोगों के मन में डर और अविश्वास का माहौल बन चुका था. हमारे शहर में प्रतिष्ठित डॉक्टर की कोविड से मृत्यु ने लोगों के भय को और बढ़ा दिया था. उस समय लोगों से संपर्क कर पाना बहुत मुश्किल हो रहा था. हमने लोगों को अपने विश्वास में लेने के लिए मोबाइल का सहारा लिया और लोगों से निरंतर संपर्क जारी रखा. जब हम लोगों के घर जाते और प्रत्येक घर का सर्वे करते, जिसमें हम सर्दी, खांसी, बुखार और विभिन्न बीमारियों की जानकारी परिवार से लेते, तो लोगों का विश्वास भी हमारे ऊपर बढ़ता और लोग अपनी समस्याओं से हमें अवगत कराते. उस समय बड़ी समस्या के रूप में परिवार नियोजन की समस्या से महिलाओं ने हमें अवगत भी कराया, जिससे हमें महिलाओं की इन समस्याओं को समझने का मौका मिला और हम इन समस्याओं को इन समस्याओं से महिलाओं को मुक्ति दिलाने में कोशिश करते रहे. जब महिलाओं ने हमें बताया कि वह परिवार नियोजन के स्थायी साधन उपलब्ध नहीं हो पा रहे हैं, उस समय अस्थायी साधनों की मांग बढ़ी. उन मांगों को लोगों तक पहुंचाना, हितग्राहियों तक उनके आवश्यकता अनुसार साधन पहुंचाना एक चुनौतीपूर्ण कार्य था. उस समय हमने परिवार नियोजन के एप्लीकेशन LMIS के माध्यम से परिवार नियोजन की समस्याओं, साधनों को लोगों तक पहुंचाने के प्रयास किए. एप्लीकेशन के माध्यम से हम लोगों का जो जरूरी आवश्यक साधन थे उनको पहुंचाने का निरंतर प्रयास कर रहे थे. लोगों को आवश्यक सामग्री पहुंचाने का कार्य निरंतर हमारी ओर से जारी था और हम
इंडेंट कर लोगों को आवश्यकता अनुसार साधन पहुंचाने के लिए निरंतर प्रयास कर रहे थे। जब हम लोगों के पास जाते तो महिलाएं हमें बताती कि उनके माहवारी के दिन बढ़ गए हैं, तो हम महिलाओं को उनकी गर्भावस्था जानने के लिए फैमिली प्लानिंग के साधनों की जानकारी उन्हें निरंतर देते और जब महिलाएं हमें उत्सुक होकर ये बोलती हैं कि दीदी हमारे साथ ये प्रॉब्लम है कि हमारे महामारी के दिन बढ़ गए हैं, तो हम प्रेगनेंसी किट के माध्यम से यह सुनिश्चित करते हैं कि महिला प्रेग्नेंट है या नहीं। यदि महिला प्रेग्नेंट नहीं है तो हम उसे परिवार नियोजन के साधनों की जानकारी देते हैं, और यदि महिला प्रेग्नेंट नहीं है तो हम उसे महिला प्रेग्नेंट है तो हम उससे उसकी इच्छा पूछते कि आप अपना बच्चा रखना चाहते हैं अथवा नहीं। यदि महिला हमें यह बताती कि हमें यह बच्चा रखना है तो हम शीघ्र पंजीयन कर महिला को उसको मिलने वाली योजनाएं और योजनाओं से अवगत कराते और उसकी ज़रूरी जांचें भी महिलाओं को कराते। इस प्रकार हम कोविड के समय महिलाओं से जुड़े और परिवार से निरंतर जुड़कर उनके आवश्यकता अनुसार उनको परिवार नियोजन के साधन उपलब्ध कराते रहे और सभी से संपर्क कर कोविड के उस कठिन परिस्थितियों में हम सबके साथ परिवार का माहौल बनाकर उनका सहयोग करते रहे। और परिवार नियोजन के साधनों को उपलब्ध कराने में हमारी संस्था प्रमुख अधीक्षक महोदय और डीसीएम सर और हमारे ऑल स्टाफ ने हमारा बहुत सपोर्ट किया। इन सबके सपोर्ट से हम लोगों तक परिवार नियोजन के साधन और ज़रूरी स्वास्थ्य सेवाएं पहुंचाते रहे। धन्यवाद।
Thank you, Vinam. I am told that in the last 2 years during the pandemic, Vinam has not taken a single leave, and she needs a big round of applause for that. These are the people who work at the grassroots and who are the ones who reach the last woman in the last village. I thank all my panelists. All of you are examples that if we all come together, we can contribute and achieve our goals of Family Planning 2030. I thank the Family Planning Division of Ministry of Health and Family Planning for giving me this opportunity to moderate this session. Thank you very much.
Ma'am, we'll request you to please stay back with us for a minute more. We would like to present plants to you as a token of our appreciation and thanks. Our sincere thanks to Dr. Ratnamala Desai. Thank you, ma'am. बहुत धन्यवाद सूरजकांत. Our thanks to Dr. Mohammad Yaqub Pasha. कहकशां आपका बहुत बहुत धन्यवाद. और हम आभारी हैं श्रीमती वेनम लोवांशी जी के. बहुत धन्यवाद, आज आप यहाँ आई और अपने विचार हम सबके साथ साझा किए. So thank you once again to the esteemed panelists. Thank you to the esteemed chair. Ladies and gentlemen, it's time to take a very short break. Please do not go on a long break when we say break. Please do come back because we like to start the next session on time. I know once the congregation breaks, it's very difficult to bring us all back into tandem. So please do try and join us back in time. I would rather request you to please join us back before time. We are starting the next session sharp at 4, so please do join us back in time. We would like to cover the time. With your cooperation, it will be possible. Enjoy the tea break, but please do join us back in time. Thank you. But meanwhile, we have work to do, so I'll request you all to please join us back. On a rainy day or otherwise, everybody enjoys tea with pakoras. I'm sure you're all enjoying the experience too, but meanwhile we have a session to look forward to, so we'll request you all to please join us back in time. As we had shared that we would be starting the next session at sharp 4 p.m. So please join me in welcoming Joint Secretary, Ministry of Health and Family Welfare, Dr. P. Ashok Babu. Our warmest welcome. Ladies and gentlemen, let's put our hands together and extend a warm welcome to the Joint Secretary who has now joined us. As we all know, he was all set to join us this morning, however could not because he was called in for a last moment urgent meeting. Ladies and gentlemen, in this session, the esteemed speakers, I request them to please join us on stage as well. We have Dr. Jyoti Sachdeva. She's from Government of Delhi and she looks after family planning, SPO she is, and I'll request her to please join us on stage. This evening she'll be talking about increasing provider base and roping private sector for family planning. We warmly welcome Dr. Sachdeva onto the stage. May I request Dr. Saswati Nag to please join us as well on stage. She is SPO Family Planning, Government of West Bengal. She would be talking about addressing teenage pregnancy and engaging youth for advancing SRH. I request her to please join us on stage. We also have Dr. S. Amrita from Government of Tamil Nadu. She is JD Family Welfare and will be talking about meeting the unmet need in post-pregnancy period. Dr. Saroj Naithani, Director FW and MH, NHM, Government of Uttarakhand, will be addressing social determinants and engaging community for addressing SRH needs. And Dr. Kalpana Apte, Director General, Family Planning Association of India, will be talking about contribution of civil society organizations to the cause of FP. So there they are, ladies and gentlemen, our esteemed panelists and the esteemed chair. A very warm welcome to you all once again. I now request the esteemed chair to please take the session forward and open the session with his remarks.
Thank you, everybody. Thank you for the opportunity. Let me start with these opening remarks. You all must be knowing that we had a tough time in the 2 years of COVID. And this has taught to the family planning division, especially if I tell Ministry of Health, it has taught us so many lessons. The first and foremost lesson is how close we are with the public and their demands. Say, people want something, and suddenly in the FPLMAS, we see the surge for some other product. That means because of lockdowns or because of some other compulsions, people want something else. Are we close enough, especially in the program like family planning, where we allow the family to rightly inform and choose the product, how close we are? These kind of meetings, where we all sit together, the contributions of civil society organizations, the unmet need, the post-pregnancy requirements, etc., are very vital for the ministry to plan and work along with the states and achieve the required goals. It is glad to see the participation of diverse nature, developmental partners, NGOs, states, and everybody coming here and discussing on various things. My last point would be, we have moved far away from where we started, maybe from the traditional methods of spacing to barrier methods to steroidal to non-steroidal, depot formations, etc., etc. We have for 2030 certain plans which we kept on discussing during the COVID times, and we try along with FP 2030 partners, we are trying to roll out few things which definitely help India in its development pathway for stabilization of the population, providing the right services at right time and access. Thanks a lot for all of you for all the time you have spent today and giving valuable suggestions. Now I look forward to certain presentations where certain new ideas of civil society organizations, private sector participants, etc. we'd like to listen and move forward. Thanks a lot for giving me this opportunity. We may start with the first presentation, Dr. Jyoti Sachdeva, Increasing Provider Base and Roping Private Sector for Family Planning.
A very good afternoon to everybody, and congrats and thank you to organizers. Thank you, sir, for giving me this opportunity. I'm talking about increasing the provider base and roping private sector for family planning. So the need for increase in provider base is obvious. In Delhi, we have 34 lakh couples, and interpersonal communication being the gold standard in communicating family planning issues. The existing medicos and paramedical staff, so-called family planning or RCH staff, is not enough to provide family planning counseling services. So the need is obvious. And we need to increase the service delivery points, that is one thing, but number of service providers have to be broadened. And that is a good foundation of any program, the skilled manpower. And in family planning, we know the demand generation and provision of quality services are the two pillars. For demand generation, which is the basic necessity, we need counselors, whether they are dedicated family planning counselors or otherwise, and we need skill-based service providers. And here in Delhi, we had focused interventions on where the gaps were. So we had gaps in IUCD provision. We did not have dedicated service providers in all PUHCs, so we did trainings for those more dedicatedly, and NSV service providers were falling short of demand generation. So these were and in private sector. So these were the three gaps we worked on over the years. So the options with us for counselors, if we talk about, either we have dedicated counselors or we get multitasking done, or we instill the sense of responsibility among the healthcare providers who are already existing. Not only family planning, the others also, or we have additional service delivery points like this also we did. Postnatal clinic, we created dedicated anemia rooms, mail windows, so naturally there will be extra service providers there, and then we integrate the programs and integrate the departments to create more service providers. So the Disha clinics for adolescent health, if we train those manpower, we can do. So looking at the pick chart of quality, where the less effort goes, obviously we will work there, the cost is less, so we started with the existing manpower. That was the only option. We did not have family planning counselors per se, and the earlier generation of family planning counselors gradually got superannuated. So we first looked at the building blocks of the communication in family planning, the ANM, ASHA and Anganwadi workers. Yes, we had 8,000 plus of them, but then to have them to talk about family planning more than so many other programs they have to look after, we have to give them some kind of, to make them active link persons, we have to give them recognition, appreciation, refresher trainings and monitoring. So we gave them all the support, and then we found that they were talking family planning and they were contributing, and that came handy in COVID also. So they are creating such good posters and slogans, and things are coming out of their mind and they are working in the field. So every year we were putting in some or the other effort to increase the service provider base. So in 2015 we had our first Ayush workshop. So the entire Ayush manpower of the state was with us in delivering family planning services. The next year saw ICTC counselors being roped in. The next year saw male nursing officers. So we trained as many number of brothers as we had hospitals to create parallel with that male windows, and there we posted them and then they delivered, and gradually we trained more and more of them. So everything was ongoing, it's not a tight compartment. In 2018 we had our Aam Aadmi Mohalla Clinic staff trained. We also started training annually the resident doctors of community medicine, starting with Maulana Azad and then going to other medical colleges also. Then we trained dietitians. I'll tell you the rationale behind all this, and then the COVID came and then we had to do webinars. We did with private sector also. We took this as an opportunity. We could not otherwise reach to them, but webinars attracted them. And since we also had a topic to talk about, we were losing interval clients, so we talked to them about postpartum family planning, and then we started having mixed groups like social workers, one-stop center people who were manning that. So just anybody and everybody, we started talking to them about family planning so that they could be our additional mouths. So we made sure that there was a nodal officer family planning as in every hospital and in every maternity home, but they as a sole service provider will not work. So we motivated these nodal officers to motivate the rest of the gynae department, and now we have all our specialists in all our hospitals talking about family planning. You can see them in the campaigns and otherwise also. Then it has to go beyond single department. Gynae department alone, it is not the responsibility, nor surgery. So our specialists started in one of the hospital, MEC wheel was introduced to all of them, a quiz was done, and that made the physicians and other doctors more confident to talk about family planning, because otherwise they don't open the dialogue thinking that some question may come which they may not be able to address. So now we are replicating such good practices in all the hospitals. So we have started with staff which caters to very relevant clients like dietitians. They are talking to parents of malnourished children, the labor room nurses, the male nurses, the ICTC counselors, and then we came to social workers, and now we think even nursing orderlies, ayahs, sanitation staff, if we talk to them, not only will they adopt, but they will also become a particular level of service provider. At least they'll be able to give some basic information. So convergence with DSACs came out successful. Delhi was one of the first few states who started this, and now all our ICTC, PPTC units are equipped, and we are doing regular trainings with them, meetings with them and strengthening with them. आज अगर हम दो ही होते 5 साल तक गोद में होते, this came from the pen of a DPM of DSACs. So this kind of leader will definitely make more service providers, more passionate ones. So people are there, we just have to metamorphose them into family planning ambassadors maybe. So the male brothers I already talked about, they started giving services from that male window. They started creating demand for the NSV surgeons who were otherwise dormant. And they also participated in various competitions. So we are trying to involve them in different ways and felicitate them and make them learn from each other and motivate them. Dietitians, when we first started teaching them at the beginning of the day, they said, why us? But the thought behind that, when they understood, they also suggested more kinds of service providers to tell us to try and teach them. So now we are going to take NRC nutritionists also. Dietitians role in FP2. This is the name of the WhatsApp group through which we communicate with them till date, and then we they keep cross-learning and they keep asking us queries and we keep resolving. The social worker training had a lot of mixed, we had OT technicians, OT assistants also. So those who are involved in NSV or they gradually become motivators, they are also trained. Aam Aadmi Mahalla Clinic I already talked about. So these are the wellness centers of Delhi. We have 50 Mahila Mahalla clinics coming up, and the SOPs are in the making, and our basket will reach there very soon. The labor room nurses, very pertinent, especially during the COVID time. We taught them postpartum family planning, FPLMIS, CS audit things in a meeting, and then we told them to take this up along with our labor room team, because this we learned from wherever we were having PPIUCD, more than 70% the staff nurses were involved. The convergence with Ayush was the most successful convergence, through which we had nodal officers in all the disciplines of Ayush. And the journey started in 2015 when the advisory came from ministry, and that we took it as a good advice and suggestion, and we knew that these partners in healthcare can be of very, very special asset to family planning program, because they spend a lot of time which family planning demands. They take a good history and they record all kinds of histories, and there was no extra expenditure. So this, through this journey, we have also taught 50 Ayush doctors, and they are IUCD providers also. And then we did a refresher training also after doing this joint efforts for optimizing family planning services. The first workshop, we did a rejuvenating and refreshing workshop in 2019, and this we are going to continue this. Then the community medicine departments of all medical colleges, we tried to rope in so that they will also, the prospective service providers they will create. Public health institutions like IIHMR, we are trying to create service providers there. Then community medicine, these are some of the activities shown. Then who else can contribute? I already said that we can also talk to guards and all. Then creating service provider pool for NSV surgeons. This was a high-hanging fruit, and we were having a vicious cycle of low number of cases and so low trainings and so less providers. And so to break this, we took a conscious decision of splitting the conventional training, alternate methodology, with due permissions of our quality assurance and with due we were following the mandates of the ministry. So we had some trainings with this kind of splitting classroom training and hands-on component. But now I'm glad to tell that today there is an ongoing training at none other place but AIMS, and there is a center of excellence for NSV coming up at AIMS. You can see it budding with all the stakeholders and all the stalwarts like Dr. Kaza, Dr. Nirja Batla involved. And in this training, we are not only having NSV surgeons to be trained, but we are also having observers from gynae department and surgery department. So they will be wanting to be in the panel for training for next batches. So next thing is roping in private sector, where I said that there is a gap. Here I needed help of other organizations getting out of our public sector, and we can offer accreditations, empanelments, and making them part of DQAC and SQAC. All these are recommendations of ministry, so easy to implement. So here we can see the yellow lines where it justifies why we need private sector to step in. In Delhi, 20% of deliveries, 50% of abortions are at private sector, but you can see the postpartum and post-abortion figures of coverage are very poor. And also they are doing a lot of cesareans, like 60% cesareans. So intra-cesarean PPIUCD has a potential here. So we must teach them and we must make them part of our system. So here we approached through associations like AOGD and FOXY and their Delhi branches, Narchi Delhi chapter, and here we could publicize our schemes and the program through these bulletins and their other platforms like meetings and all. And two major initiatives that we took in collaboration with FOXY were, one was a PPIUCD training in private sector. 2 batches have already been completed, and here also we are splitting the virtual and the on-site component, and here also we are sticking to the mandates of criteria to be fulfilled for certification. The second one is we have prepared a module on basic family planning counseling, whereby the vision is that all health care providers in public and private sector to be taught basic 4 things: overview, general counseling, method specific, male participation, so that they don't feel shy in communicating or starting a family planning dialogue and they know where to refer. So the first TOT was on 22nd July, and 12 Ayush medical officers here also were trained as trainers, and 25 specialists and 10 experienced family planning services. This is the Delhi figure. Then we are also training since this is a virtual thing, the TOT is virtual, the rest of the cascading may be physical or virtual. So we have trained other states also. So challenges are there. There are people who still have a mindset that it is a one-man's job, and private providers sometimes think that their clients do not need family planning, and there are so many, but we have tapped the opportunities like additional man-force of civil defense volunteers during COVID, and we use other program campaigns and other tasks, like if we are talking about cesarean audit, we do ask them whether they offered PPIUCD or not. So all these efforts have led to a drop in unmet need in Delhi, but we have a long way to go, and so we are planning more and more trainings of more categories of people, including one module, like Kaikasha was saying, that Yuva people should be given training and they should also be involved in the module making. So Narji Delhi is helping us to prepare a module for what to be taught about SRH in schools, and here also we will be doing TOTs, and we will be involving lots of more people. Like nutritionists, pharmacists, managers, coordinators, all those. And already roped in staff needs to be supported more, and their documentation, so that we can really feel more happy about it. We are going to private sector during their meetings and trying to teach them MEC wheel, PAFP, PPFP. And state level workshop is envisaged. It was proposed in this ROP, it was approved, and we will be soon doing this, whereby we will invite the private practitioners, the bigger ones and the smaller players also, to motivate them, because it has to go sarvasva sarvatra, that is what we have been listening since morning. So my key messages are that from gynecologists there has to be a shift to all medicos, and from medicos to paramedicals, and to all healthcare providers from public to private. We need to move from casual mention of family planning to skilled dialogue, so that they talk convincingly, from respectful maternal care to respectful family planning care also, from seeking indemnity, this is the attitude of the service providers we are talking about, to responsible participation. So thank you. Together we can do it. So I think जोत से जोत जलाते रहनी चाहिए और provider base को बढ़ाते रहना चाहिए. Thank you so much.
Thank you, Dr. Sachdeva. We'll have a time separately for discussions. Now I request Dr. Saraswati Nag on reflections on teenage pregnancies and engaging youth for advancing SRH.
Good afternoon, everybody. I want to thank the National Family Planning Division also. Now, West Bengal has achieved the replacement TFR. We have already reached 1.6. Our main challenge is now teenage marriage and teenage fertility. Teenage marriage is almost at the same level. If we compare NFHS 4 and NFHS 5, it's 41.6%. Teenage fertility is declining, but not much. Still, it's quite high, and we need to address that. The % contribution to fertility, though declining, is still quite high in West Bengal. If you see, the percentage of teenage couples is only 3%, but percentage of pregnant women of this age group is 22%. So this is also a major issue in our state. The contraceptive use, as we see, is the contraceptive method mix can be quite visible, it's mainly CC, OCP, and injectable also to a certain extent. What we perceived of late,
while meeting with the teenage couples that the proportion of girls getting married themselves is quite high than the parents forcing them to marry. So this was an observation that we got from the teenage couples, meeting with the couples. So we started tracking eligible couple right from marriage, as well as we had another option was to strengthen the AFHC clinics at our facilities. So we are tracking the eligible couples right from marriage, and that is through our state-developed portal, Tracking Maternal and Child Health Service, the Matrima portal of our state. We are registering them just after marriage. Our Ashas are mobilizing the teenage couples to our sub-centers, and on a fixed day in a week, we are meeting the teenage couples, the eligible couples right from marriage. We are tracking them. We are focusing on preconception care of these young couples. Counseling by the AFHC counselors. We are detailing the AFHC counselors and the RMNCH counselors also to these facilities, because what we are seeing that the counselors were mainly stationed at the facilities. The outreach services were quite less. So now we are focusing on the outreach services of these counselors and counseling mainly on nutritional habits, on healthy behavior, as well as on family planning methods. Mostly focusing on delaying pregnancy for at least 20 years. We are trying to involve the peer groups also, and focus group discussion we are having in rural as well as urban areas. The incidence of teenage marriage as well as teenage pregnancy, as we were seeing, is higher in urban areas also. We started tracking them from this year only. We have strengthened this tracking mechanism. From April, if we notice, the couple protection rate of teenage couple was increasing. This was not only because of the performance, but we are focusing on data-related issues also. Data entry in the portal, that was also an issue. And we can see from 11 July to 18 July, especially during the mobilization fortnight, this mobilization phase of WPD, the CPR was increasing. So we were focusing on mobilization and counseling of these couples mainly in this fortnight, and we are getting the results also, though not much, but at least to a certain extent. We need to strengthen this further. Now challenges, another challenge is birth order 3 and above, which is declining but still contributing 8.2% in our state. The usage of modern contraceptive has increased from NFHS 4 to NFHS 5. The unmet need has also declined, but still there is a scope of improvement and a lot of work needs to be done. Now we have started emphasizing on permanent methods also, which has declined substantially, especially during the pandemic. We are trying to improve that also. This is the data of the public facilities only. We have not taken into account the private facilities. The postpartum sterilization, however, is increasing to a certain extent, because now we are mainly focusing on the postpartum period, because incidence of pregnancy, on second pregnancy of teenage couple is also high. So we are focusing on fixed day service at all blocks, tagging the gynecologist to the non-performing blocks, and now we are focusing on counseling in urban areas. As we said, the incidence of teenage marriage, teenage pregnancy, this was increasing in urban areas. Now after 15 Finance Commission, we know that we are getting additional 1,500 facilities, urban health and wellness centers. So the service can become more accessible to this population. We can reach out to the population also. Postpartum period, after focusing on these postpartum period, we have seen noticed a rise in the PPICD percentage from 21% in 2016-17 to 46% at the end of 21-22, and of late it's 48% at present in this financial year. If not PPICD, then we are discharging the clients at least with Chaya. We are trying to counsel them and discharge at least with Chaya. And that also we can see the performance has increased substantially. And after 6 weeks,
focusing on giving them Antara. This we are mainly tapping the clients at immunization clinics. Those clients who are attending immunization clinics with their child. Now we are focusing on early registration of pregnant women. We have seen that these teenage couples, we are getting the couples only after they become pregnant. So as I mentioned earlier, we are trying to track them right from marriage, from the preconception period. After registration of pregnant women in the first trimester, we are counseling them on adoption of family planning method right from the first trimester. We are focusing also on the skill development of the counselor. Counseling on family planning services, as I said, from first trimester ANC checkup only. Quality training of providers. It's not that we were able to train all the providers. A lot of work still needs to be done. But we are focusing on quality training of providers, training them in medical colleges. We are also getting support from IPAS Foundation for this training of counselors as well as providers, on-site training and also follow-up, tapping clients at 6 weeks, attending immunization clinic. West Bengal, there's a contraceptive method mix from sterilization only to the proportion of spacing methods is increasing, female sterilization as well as other methods also. Now with 7.5% of the India's population, our contribution to the national figure, as we can see, deliveries is 6%, but postpartum sterilization 11%, PPICD 30% of India's coverage, PICD 10%, Antara first dose 12%, but this is important, Antara fourth and above. We are trying to follow up these clients, sustain the method, and this 27%, as we can see from the national figure, 27% contribution to Antara fourth dose and above. So this is area we are mainly focusing on, continuation of the adopted methods, combined oral pill, which was quite high in our state right from beginning, and it has increased further as we are counseling teenage couples more and more. CC 8% only, but we need to increase this. Of late, we are trying to increase this. Centroman, as I mentioned earlier, Chaya, that is 14% of India's figure. As I said, emphasis on basket of choice. So our rank of the state in different contraceptive practices. Postpartum sterilization, postpartum IUCD also. So we are focusing on all the methods, method mix in family planning, not only on a single method. And now we have a lot of work still remaining. We need to distribute contraceptives to a greater extent, not only to married couples, but also to unmarried ones, as we can see that teenage fertility is quite high. So a lot of work still remaining. Thank you.
Thank you, Dr. Nag. Now I request Dr. S. Amuta for reflections on meeting unmet need in post-pregnancy period.
Very good evening to each one of you here. First of all, I thank the Almighty for gracing this day, and I thank our Ministry of Health, and my heartfelt thanks to our Sikdar sir, who is of great inspiration to everyone in our directorate. The topic given to our state is meeting the unmet need in post-pregnancy period. So first few of my slides will be on general in general, and remaining will be on pertaining to our state. By definition, we all of us know that women with unmet need are those who are sexually active but are not using any method of contraception and not wanting any more children, or they want to delay the next child. And WHO says that unmet need for family planning provides a measurement of the ability of women in achieving their desired family size and birth spacing. Unmet need complements the modern contraceptive prevalence rate by indicating the additional extent of need to delay or limit births. The concept of unmet need points to the gap between women's reproductive intentions and their contraceptive behavior. All of us are very much aware through family planning services, we'll be able to reduce 2/3 of the maternal deaths and 10% of the infant mortality rate. So among our total eligible couples, we are bothered about those who are not using modern contraception or non-acceptors who may become pregnant or non-pregnant. Among the pregnant group, the unplanned, they land with mistimed or unwanted pregnancy, and among who do not conceive, they may intend to use the modern contraception, or they don't or they intend to use it. But even then, those all these categories are very important, who are the group for the unmet need among the eligible couples. So we need to take care of these persons. So the common reasons that we usually come across for the unmet needs being the concern about health and side effects of contraception, which the mothers, they do get from the peer group. And the next, usually they have a common belief that during breastfeeding, mothers do not become pregnant. And the most next common being the partners who oppose the use of contraceptives, and the other remaining reasons being on the provider's side, that imbalanced and improper contraceptive supply chain management in very remote areas, and at times when we are meeting out short supplies, all these things they contribute, and lack of service availability and logistic simplicity is also one of the reasons. So silent phases of unmet need in family planning are always women. Why always women in family planning? So here we have come to understand the need for contraception, and the type of method needed is also likely to change over a women's life course. In the morning sessions, we are all hearing about the change that is taking place, which is the modern contraceptive prevalence rate is being increasing in the nation, which is a good sign right in front of us, where we have to give the sustained effort. And globally, we are aware that 61% of women are not using effective contraception within 24 months postpartum to avoid an unintended pregnancy. So we need, the big question in front of us is, why always women in family planning? For which all of us have to join hands to get a correct right answer to take the community and fulfill the need of every woman in the world. So where Tamil Nadu stands. So as per NFHS 2 survey, our unmet need was 13, and as per NFHS 5, it has declined to 7.5. And the modern contraceptive prevalence rate, as it unmet need complements modern contraceptive prevalence rate, it from 44.5 during NFHS 1, it has now reached 65.5, which is also not enough, where we have to work hard. And trending in immediate postpartum services, as far as our state is concerned, for the past 6 years, we could see a slight decline over the permanent method and an increase in the postpartum IUCD. And postpartum permanent sterilization, 77.0% is our postpartum sterilization, and postpartum IUCD is 84.7%. So our state unmet need being 7.5, among limiting method, it is 4.5, and the 3 in the spacing method. Out of our 32 districts, along with the newly formed 6 districts, we could find out that nearly 15 districts are above average in relation to limiting methods, and remaining 17 below the state average. And in a spacing, it's the reverse, 17 districts on the higher side and 15 on the lower side, and 8 districts are common in both limiting and spacing, where the 8 districts have to be given more attention. The common determinants being women, education, employment, and media exposure. The domains where we need to focus is based on community group and the service providers. On the community side, we have to look upon the educational weaker pockets, scheduled community colonies, tribal residing pockets, remote and farmost hamlets, inaccessible areas, urban slums, young married women, religion, etc. And when we come to the service side, we need to give adequate service facility for logistics simplicity, and we should have adequate trained service providers. When they do leave the facility, it has to be an ongoing process where at times we do have a difficulty. And demand generation through IEC, strengthening counseling services, and commodity management through FPLMIS, home delivery of contraception, public-private partnership encouragement. So how we are going to do it, and this is what we are now at: continuum of care, contact points where family planning has to be integrated right from antenatal period. During antenatal visits, the mothers are being counseled to choose their contraception which would be right for them and which will be feasible for them. And if we do miss during that period, then they are being tracked, and at birth, during intrapartum, as well as immediately in the postpartum up to 7 days, the mothers are given counseling by the counselors, and at that time also they are made to accept contraception. And the postnatal care visits in the up to 42 days, and even after extended postpartum period, during well baby clinic, immunization clinic also. Now we are concentrating on immunization clinic, where the mothers who have not accepted are given, the line list is given to the VHNs and field staff to track them and bring them understand the importance and accept contraception. Our implementation experiences, investing in good documentation and monitoring, which is very important, so that we'll have an idea and follow frame strategies accordingly. And as it was discussed in the morning also, updating of National Service Delivery Guidelines to service providers, both public and private, where right from the state level, district, block, this quality care services, how it has to be provided in family planning. It is being taken through workshops and many seminars. And the social and behavioral change strategies, where we need to bring a change in the social behavior. So this is being clubbed in our state with the health system reform project, where we are looking forward. We have initiated recently, and we look forward a good social and behavioral change among the community. And then postpartum family planning adoption among first-time young parents. Here we have got the Dr. Muthulakshmi Reddy's maternity benefit scheme, where many of the young primees, they are counseled and they do accept postpartum contraception in the form of PPIUCD, where we are able to achieve 84%. And commodity management, FPLMIS is a very good strategy and methodology, where we are able to follow. And we last 2 years back we were at a very low level, and now with strain and effort we are able to achieve 50%. We have roped in all the centers, right from health sub-centers, PHCs, district headquarters, government hospitals and medical college hospitals. All have been roped and it's being followed. Intent is being raised, but on the client side we are yet to achieve. During antenatal visits, all the clients are given education on modern contraception. Not only the client's spouse are also called, and they are also being given education. ensuring family planning acceptance prior to the discharge of the mothers. This we practiced last 7 months, where we had the report, everyday reporting from all the hospitals, right from medical college right up top, bottom to primary health centers. So they need to give who are the mothers who have left without accepting family planning, contraception or permanent sterilization, and this list is given to the Deputy Director Family Welfare Bureau office, and from there it is distributed to the concerned centers, PHCs particularly, and the field health functionaries, VHN. They track the line list and they find out the mothers who have not accepted, and they do counseling and make them accept, and we have followed it, and at the medical college and government hospitals we were able to have good coverage, and at PHCs we were left behind with mothers who have not accepted, but this is now being put into practice. Hope we will have good results in future. And increasing male participation, even before, right from our RCH period, male participation in our state is less than 1%, and we are looking forward, and during last NSV fortnight last year, and also following that, our district administration have come with giving incentives and motivating the fathers to accept, not only for accepting NSV, for to give respectful care to women in relation to the reproductive health. Ensuring the availability of adequate staff, equipment, supplies and consumables. This is also a major portion where everyone has to pay attention every day, so that nowhere it goes stock out. So way forward, community-based peer system for young women. Here we have the young generation who have to be educated. So here we look forward for giving the age at marriage, safe sexual practices, and knowledge about emergency pills, and also safe abortion services, which is most important, where many of our children below 18, they do land with many complications due to unsafe abortion practices. So focus on high unmet need districts, the districts which have been identified as high priority districts, they are given close attention, and the 10 districts have been identified and 2 among aspirational districts, and these 10 districts are provided with the family planning help desk at headquarters hospital, medical college and government hospitals, with the family planning help desk, where the counselor is there to give all the contraceptives available, so and teach them, and it is a basket of choice is displayed in front of the partners, and it is well explained, and they help to choose the contraception in either the immediate postpartum or the late period according the patient's need. And the family planning card for every mother is provided with the family planning card. So this card is tagged with the immunization card, and the one part of it contains the details of the mother, and the other one is the IEC part, which is given to the mother. So this is being followed by the VHN until they accept the contraception, either permanent or temporary. And for those people who have left out without accepting, we have got the outreach services, family planning mobile services. In this, the 3 of our high priority districts are provided with family planning mobile services with IEC materials and display of all the IEC with short films, which we could see in the picture, and counseling, and with the commodities. You could see the rack with the commodities will be placed inside that rack which is provided. So whoever wants any contraception, to know about contraception, they are given, and they are taken to the nearby PHC to avail the service. The impacts of meeting the unmet need under sustainable development goals, good health. So here we have got only one key indicator, modern contraceptive prevalence rate, where our state stands with 65.5%. We need to reach 70 by 2030, for which we have to work heart. This will help us to prevent large number of unintended pregnancies and reduce the number of abortions, unsafe abortions, and reduce the incidence of deaths and illness related to pregnancy and childbirth, and it will reduce inequalities in knowledge and overcoming social and cultural barriers, and to ensure high quality services not only in government but in private sector also. So together we can make sure that no woman has to face an unmet need in future. Thank you one and all for your patient listening. Thank you.
Thank you, Dr. Amrita. Now I request Dr. Kalpana Apte, contribution of civil society organizations to the cause of FP. Thank you.
Good evening, respected Dr. Ashok, Dr. Sikdar, and friends. Thank you, first of all, for giving us this opportunity to speak about the contribution of civil society organization to the cause of family planning. Today, from the morning, we are celebrating the 70 years of family planning in India. And I'm really happy to say that, and we have also heard that India was the first country in the world to include family planning in its health planning. And actually, at the root of it, very few people know, was the civil society contribution. And I'm very, very proud and privileged to stand here in front of you and say that it's the legacy of Family Planning Association of India that the founding members wrote to the Government of India pleading the case of family planning, and the then government accepted it and included it in 1952 in the first plan of the India's developmental plan. So I would say that civil society organizations are integral to the development of any country. The more robust civil society organization pillar is, the robust democracy and the robustness of its program can be seen. And if we were to very quickly see the contribution of civil society organizations to India's family planning, I cannot claim to take or represent all of them, but I could certainly speak on behalf of some of the friends who are sitting here and share some of the examples of how civil society has been able to contribute to the program. Civil society organizations they are not cut and dried kind of organizations, popularly known as non-governmental organization. They are different kinds of entities. Some are registered for profit and not for so profit. Some are semi kind of private organizations. So basically these are, if we can very broadly categorize, we can say these are the bridge between the civil society or the society and the community, as well as then the government. And if we use this very broad and loosely defined kind of entities, then we see that there has been immense contribution of this group of people and NGOs and CSOs and local voluntary groups to the cause of family planning. We have played a supportive role, and a supportive role which comes like technical support, consultative support. We have provided technical support to the government and to the society wherever it was required by way of providing training and giving clinical training, giving the counseling training. So many kinds of trainings have been provided. We have also played a consultative role, and I think that kind of a role is very structured and well built into our programs and processes and committees. There is a seat or a place, very much well drafted and well qualified place for a CSO in these kind of committees, which could be Rogi Kalyan Samitis, or this could be quality monitoring committees, or many kinds of committees which have a specific role for a civil society organization. So that kind of consultative role. We also provide implementation. And who can forget about more than 10 years ago, a very well known and very well strong scheme, which was Mother NGO and Field NGO scheme, which was completely invested in and managed by the civil society organizations. One civil society organization in each of the districts of India, and it was monitored by a mother NGO, and then there was a regional resource center which provided capacity building. So a huge and immense role has been played by the CSO in our country, and we continue to play it. There are some other things also, primarily bringing the voices of the communities, different kinds of communities, to the policy tables so that their voices can be accounted for and thought about how can we reach everybody. Basically, it is a partnership. If I can say that the CSO play a role of an important partner to the Government of India. Government of India really is a very forward-thinking government which has built so many spaces, yet it requires the support of CSOs in many other ways. We also provide models by implementing new and innovative kind of implementation schemes. It could be Prachar, and some of these have been even included in the booklet that the book today we have received from the government. Prachar, who can forget the project Prachar by Pathfinders. We, FPA India did a similar project in Barwani district where we were able to raise the contraceptive prevalence rate under 19 married, under age of 19 married adolescent. When we started in the district, it was 1.9% CPR, below 19 married couples, and when we left about after 36 to 40 months, it had come up to about 38%. So we provide models. We do take on difficult areas and find solutions and share our expertise and our findings, or even sometimes our not so successful pathways, so that lessons can be learned together. I would say that NGOs play an important and another important role which is not very popular, and that is of reality check. I think it's an important role that we are the conscious keeper sometimes, if you will, or we would also be able to do a reality check of what's really happening. Bringing it straight from the field to the tables of, and I have been working in this field for last 30 years, and in my 30 years, out of that around 22 to 23 years, I have worked very closely with the Delhi government of India, and I must say I have not seen anywhere else such kind of receptivity, openness, and a space for NGOs that exists there in the Ministry of Health and Family Welfare and in Department of Health. There has been a lot of openness and acceptance in hearing from what we have to say or sharing the information. If there are problems that we face in the field, then those problems have been sorted out and supported. At the end of the what I want to speak, I would just like to say that in these days, the roles are changing, the spaces are changing, and I think as India changes from being from the last century to this century and moving on, I think we as CSOs also will have to do things differently to see that we still remain relevant. The spaces are becoming scarce and they are becoming a little challenging, but the work on the ground is changing. Family planning in India is changing, and so we need to also change ourselves to be still relevant, to provide those kind of solutions. India doesn't only need now demographic approach to family planning. We need to move on with an individual and a rights-based approach to family planning. How we together collectively as a CSO be able to provide that kind of a view and that kind of model which can say that, okay, we move on from being a demographic to a more rights-based family planning program. So these are some of the things moving forward. I am extremely thankful that this position, this space and this opportunity was available to us to speak about ourselves. I do not, as I said, I do not claim to represent all the CSOs and CSOs. Whatever I have been able to tell you in last 8 minutes, we do much more than that. And so thank you, sir, for giving us this opportunity. And if there are any questions, I would like to take that. Thank you so much, sir.
Thank you, ma'am. Now the floor is open for discussion. We can take inputs or comments or questions from the participants. Thank you. Anybody? Any questions, comments? No hands up or... Yeah, please. Can somebody pass on the mic there?
I'm Dr. Emirumi, Director of Family Welfare, Arunachal Pradesh. I have a question to Saswati. You were presenting on the teenage marriage and teenage pregnancy in West Bengal. Could you attribute the cause of teenage marriage and teenage pregnancy? Though you are working very hard, but still there is lots more to do. Is it because of amongst the low socioeconomic reason, or is it failure of certain government policies and programs, or do you find any differences amongst the religious followers of West Bengal, where you have a prevalence of teenage pregnancy and teenage marriage and pregnancy is still high?
On from there, man. This is a small button. Here. Yeah.
What we observed is there is no difference between religion. Incidence of girls marrying themselves, especially in urban areas, this is rising now, rather than parents getting their daughters married at a younger age. So I think maybe media and social factors, they may be contributing to this high incidence of teenage marriage. Teenage fertility, as we said, is declining, but teenage marriage is very high, and it's almost the same from NFHS 4. There is no religious difference as such. We feel that the socioeconomic status and the media may be more access to this digital environment. This has led to increased incidence of this teenage marriage.
If you have to go to family planning 2030, I think this will be a challenging steps towards bringing the teenage marriage and teenage pregnancy, especially in West Bengal, which will be an eye-opener for all of other states, which I believe. And I think when the government has also taken a decision to raise the age of the marriage of women to 21, I think that should also take care of lots of problems. And secondly, I feel which we heard this morning from a youth, both the youths, they were very candid about what they want now. They were very, very candid about what the youths of the country now requires. I think that should be an eye-opener for all of us, so that if we have to bring down the incidences of teenage marriage and teenage pregnancies, we need to take a bolder steps. Thank you.
West Bengal, we hope that teenage marriage will decline. We hope to get a better result in the next NFHS.
Any other questions? Yeah, please.
I'm Dr. Shobha Gudi here, reporting from Foxy. I'm the chairperson Family Welfare Committee, and many of my friends are on the dais, and we have collaborated quite richly in the last 2-3 years to bring forward some interventions. What I wanted to say was, I think going forward, there are 2 or 3 aspects which will deserve more attention on our way forward to 2030. One would be that there has to be a higher quality of training, especially in the private sector. And we have made that effort. We have tried to bring in PPI-UCD awareness and training in the private sector practitioners. And we have tried to do structured awareness building for them through a regular certification process, etc. And I did get a lot of help from Delhi State. We tried to bring in awareness for NSV also. My request to the panel today is that probably the awareness in the communities, in the target populations regarding contraception is still not what it should be. So however much is our effort, it is like the receptivity level is still kind of not optimal, because still that fear and that misconception is there, and that is uniform. That is not just in the public sector or amongst the less affordable. It is in the private clientele also, perhaps more so, because there is a lot of misinformation which they do read in the internet. So that is one thing where we could progress, and we could join our forces, private and public sector, and all of us. The other one is on the related to this is the demand generation. I think that is one thing which is putting every project under a cloud when we start, and women are simply not able to come forward and seek contraception. So contraception seeking behavior, secondary to poor perception of demand generation, is what we are looking at. So I think the experts will have to bring forward some direction to this, so that we can have some short-term goals together. We can have a 3-month goal or a 6-month goals towards which all of us can work synergistically. Thank you very much. Thank you.
We can take one more last, or we can close it from any. Yeah.
So, good evening, everyone. I have a question with Dr. Jyoti Sachdeva. First of all, ma'am, I like the way the capacity building and the possibility of engaging even the nutritionist, the way you people have explored it. I just wanted to know what was the experience when you have involved the NRC dietitian for the family planning. Because that is one of the missing window which actually we want to explore. We always thought of other type of counselor, but we never thought, like I'm coming from UP, we never thought of involving the NRC dietitian. So what are the learnings of involving the NRC dietitian for the family planning counseling? I'm Dr. Rinku. I'm Dr. Rinku Srivastav. I'm GM Family Planning NHM, UP.
Okay. So thank you so much, ma'am, for bringing this forward and appreciating our efforts on going up to the dietitians. The experience initially when we thought of this, I had to face some kind of resistance even from medical superintendents from whom we asked the nominations. They said family planning, why? And in fact, we also called the dietitian of super specialty hospitals, and where the MS was very closely known to me, and he said, what is this? You are pushing family planning everywhere. What does GB Pant have to do with family planning? So then I said the super specialty departments have patients who need family planning more than anybody else. A woman who comes with heart disease and pregnancy, and we have to manage whether MTP or continuation of pregnancy, only the obstetricians know what kind of nightmare it is. So that is what that was the first bottleneck we faced, that we could not get nominations. Finally, we made sure that all the hospitals where dietitians were there, whether they were assistant dietitians or the senior most dietitians, they all attended our training. And the training started, as I said, with what is our role here. So through the day, they were more than convinced. And the very next day we formed a WhatsApp group, and I started getting, experiences from them. And also I started getting queries. This is happening, what to do? I had given this to a patient and now she's having this, what to do? So we are, holding on to that. The next thing was that we wrote to the medical superintendents and to the district program officers after doing this, that they should have continuous support to them. So we gave them a contraceptive basket. So today every dietitian's workstation has a contraceptive basket, and they do talk about that. And many of them are talking to clients in reproductive age group, and many of them have malnourished children. So who else needs family planning more than these parents? So all this was realized gradually by these people. And nutritionists are with us. They are even, as I said, once they start working in the field, their mind starts working in that. And then they come up with such creative, dialogues and experiences, and even they compete in the competitions, and then we felicitate them also. Recently from SVBP hospital, we felicitated a dietitian. She was sitting amongst the rest of the doctors, and she said, I am feeling so proud. If it was not for family planning, I would never have come to this platform. So similar thing we are seeing here also. We have to hold hands of people and then go forward. I think that answers your question, ma'am.
With this, I thank all the experts on the dais and participants. We close the session number 4. I request Dr. Sigdar to take it further, the closing session ahead.
I request all the esteemed panelists to please stay back with us for a minute more. We'd like to present green plants to you as a token of our appreciation and thanks. In no particular order, we thank Dr. Jyoti Sachdeva, Dr. Sashwati Nag, Dr. S. Amuta, Dr. Kalpana Apte, and our sincere thanks to the esteemed chair. Thank you. We're thankful to the Joint Secretary, Dr. P. Ashok Babu, for having chaired this session. Thank you, sir. Thank you, esteemed panelists, for joining us here today. And now, ladies and gentlemen, we have almost come to the end of the day's proceedings. To take us forward, may I invite on stage Dr. S.K. Sigdar, Advisor, Family Planning and Maternal Health, Ministry of Health and Family Welfare. Since this is the closing session, I now hand it over to Dr. S.K. Sigdar to take the session forward.
Mic is, now it's working. Okay, fine. So we are coming to the last part of this program. I know the energies may be sapping right now. But I think probably this is the right time for exercising your brain a little bit in terms of we want to have a polling on the Mentimeter poll, and we want to see how you have, or rather you have opinions and ideas of taking or answers for the various questions that we put to you. So this works like this. Will be a sort of a paper given on your table, which it's there on every table. Just check if it is there on every table. So you'll have to scan it, and questions will come, and then you give your response. For every question, we'll give you 1 to 2 minutes, and you will be filing your response. And at the end of the responses, we will be able to get that what are the things which are coming out prominently in the questions that we are putting you to. So can we start? Everybody has got the scanned paper on their table.
Yeah, it's just a request. You can open the Google Lens of your phone and just scan the code.
Are we ready? Mithun, 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 इधर.
सब शो होगा कोई भी
तो मेरे को भी तो करना पड़ेगा मैं कैसे करूँ
अनाउंस कर दीजिए उसमें menti.com डिस्प्ले कर दिया हमने
तो मुझे नहीं पता ना क्वेश्चन क्या है
नहीं आप बोल दीजिए अगर स्कैन कोड से नहीं हो रहा है तो menti.com खोल के वो कोड दिया हुआ है
मैं वो नहीं कह रहा हूँ मुझे तो पता नहीं ना क्वेश्चन क्या है
नहीं वो लोग एक्सेस कर सकते हैं कुछ
तो मेरे को भी पता होना चाहिए क्या एक्सेस है तभी तो आएगा
इसको बंद कर दीजिए
वही कह रहा हूँ ना यार
एक कोड यहाँ से
So if some people are not able to access from the scan code, I think there is on the top there is a Mentimeter. This thing you go to that particular site, you will get that. Am I right? Now code is there.
List of questions. First question is starting. First question is starting.
So if you are ready, then we are starting with the first question. So what is the one important strategy to achieve universal reproductive health coverage till the last mile? So we want to see your response, which will automatically congregate on this particular screen in front of you. So we will know that what is the majority of the people thinking on this. Start polling. Community engagement, okay. Innovation, collaboration, awareness, choice-based strategies. So now they are coming thick and fast. Education, convergence. So community engagement is winning the day. Family. So I think that's about all. By and large, I think everybody has polled. Everybody is polled? Some people are yet to poll.
39 people have polled.
39. So we have around 200 or 250 people over here. 39. People are not interested, one can see. So the community engagement is not there. The community is not interested. Shall we take it like that? 42. We touch 50 when we close, right? 53. Okay, fine. We close this. So the thing which is coming out strong and strong in this is community engagement, education, awareness. All are quite linked to each other. By and large, the words that you have put in over here are something that we feel is very important to achieve universal reproductive health coverage. So thank you for this. We move to the next question. What is the one focus area that will pave the path for future family planning strategies? It's a very loaded question. What is the one focus area that will pave the path for future FP strategies? So, especially for the program officers, this will be interesting. In which is the way or which is the road that they need to traverse for the future FP strategies? Male participation, youth engagement, young people. So here we can see it's the young people is coming in big, and yeah, everywhere it's young engagement and male participation. 50. And so I think we were very right when we came out with the vision document in the morning. The first priority areas we talked about was adolescent and youth, and that is reverberating across this particular room, and everybody is on the same page. We are talking of youth engagement, youth as well as male participation. So male participation is another area where we are putting in a lot of efforts, and thanks to many of the states which have come out, and we believe going forward this particular area is that we can strengthen further. We are doing well, but we need to revive our male participation both in condoms as well as sterilization, as well as participation in the reproductive arena work. It's not just about adopting a service, but also about participation in the future FP strategies. Okay, fine, thank you. Let's move to the next question. So this will be a ranking. The bar graph will tell you. You have the options. How best do you think we can improve male participation in family planning? We deliberately put this question because this area we feel that we need to work much more. So male health workforce, or male clinic, male-centric social and behavior change communication, youth engagement, demand generation, and promotion in jobs, incentives. So which one is scoring? Let's see if some other bar beats the other bars. So here it is. We are talking of male-centric social and behavior change communication, and demand generation. Again, there is a fight between some of the bars. Male health workforce. How many responses? 46. Some more? So male-centric social and behavior change communication is one area which this particular group is talking about. We have developed many of these things is something, but unfortunately it is not across the states. In some places it does well. Youth engagement is one area probably for us to revive. So if all the youth members from different coalitions, if they really in their groups talk about male participation right at the outset, maybe then this particular change will come over the next 2 to 3 years. So the responsibility on the youth also now increases to take this message forward. Workforce is something we already had, but it's all a dwindling sort of a category, dwindling cadre. NHM is trying to have male workforce revived. It will take some time for us. Some people have mentioned about male clinics. Now this is a very attractive proposition because I remember about 8 to 10 years back, or rather 10 years back, we talked about this particular initiative, male clinics, because I was told at many of the places that women have plenty of clinics. Wherever they go into the hospital, it's ANC clinic, counseling clinic, everywhere you women have everything. But there's no dedicated clinic or place for males. That was a very bright idea. I think if some states could take that particular initiative, I think Jyoti can lead the way. You can have clinics. And also I think West Bengal can also, because they also had very good participation. It has gone down. So let us see it as a pilot. And this is actually, if you remember, it was Dr. Kaza's idea to have male clinic. And we tried it in Jharkhand, in the district of Bokaro. We did that. But again, it lost steam because of loss of support. So maybe we need to revive and see if the male clinics can do the work. So let's move to the next question. The fourth one, again, I think it's a bar-centric one. What is the realistic and acceptable strategy you suggest for reducing unmet need for contraception among young people? So let's the young, I am requesting the young people to vote in huge numbers in this one. Realistic and acceptable strategy you suggest for reducing unmet need for contraception for among young people. Waiting for the responses. Awareness. Well, female. Availability of FP commodities. Awareness. We'll wait some more responses. So awareness is coming out loud and strong here. I'm quite surprised because not many people have talked about availability of family planning commodity. Because that is one area where the government is working very hard. We are coming out with safe kit, the condom boxes and all these emergency contraceptives and pregnancy testing kits. So availability is one area where we have to work very well. Awareness again is one area now that you mention it. We'll have to see that how we can increase the awareness in male part about the young people. Also, we have seen that it's the girls who have better knowledge of contraception than the boys. This has been our experience across the country. So girls, probably the peer groups actually provide more information. We had interviews with peer educators in many of the states, and we found that the girls among them were much more knowledgeable about the contraceptive choices and methods than the boys. So anyway, so we move to the next one. This is again a ranking based on bars. What are the areas where your organization or state can partner best for achieving universal reproductive health goal? I believe there are so many organizations standing. Last question I know. So what are the areas that your organizations and state can partner best for achieving universal reproductive health goals? So, it is too small for me to read also. Mainstreaming youth. Okay. Second. Social marketing of contraceptives. Mm-hmm. So the mainstreaming youth remains at the top, right? And some people are saying social marketing. So some of you are already social marketing organizations. Maybe you need to scale up. We will try to support it from the government side. In terms of the mainstreaming youth, again, this area is again up to the agencies as well as the state, that how do you now going forward into your program planning, your future roadmap, you probably have to take the youth along, just as we did in our summit today. We had sessions from the youth who are actually among the ones who are working in the field. I think the states now need to move fast on that area. Only then probably we'll be able to get the dividends. So with that, we come to the end of this Menti polling. I think it was very refreshing, and at least it really awakened many of you. So from that point of view, it was a mental exercise. We call it Mentimeter, and I think it's achieved its purpose. So that's about all about today's program. About the conclusion, I don't want to make any concluding remarks because I think everything has been said since morning. Only thing that we want to say is that, as Dr. Jyoti mentioned, and how Dr. Jyoti convinced a neurologist or neurosurgeon or a cardiologist or cardiac surgeon. She mentioned GB Pant Hospital. GB Pant Hospital is a super specialty hospital for neurology and cardiology. If she could convince the neurologist and cardiologist there, I think there is hope for all of us. We need to explain the importance of family planning, how then it can really have a great impact socio-economically, socio-culturally on the whole society. and in addition to getting the dividends in terms of reduction of maternal mortality and morbidity and infant mortality and morbidity. That's the parting message, that family planning is for improving maternal health and child health. And with that, I think we come to the conclusion of this particular summit. And thank you all for staying till now, till the conclusion of this summit. And I believe and I hope that this has been a successful experiment and experience for both of you and for us in the government. Thank you very much.
Thank you, Dr. Sikdar. And I now invite Dr. Divya Valeja to please join us on stage. Dr. Divya Valeja is Assistant Commissioner, Family Planning, Ministry of Health and Family Welfare. And may I request her to please propose the vote of thanks.
Thank you, Mandeep. It gives me great pleasure, and I consider it a privilege to stand in front of this great gathering today to propose a vote of thanks. I am thankful to our Honorable Minister, Dr. Mansukh Mandaviya ji, our Honorable Minister of State, Dr. Bharti Praveen Pawar ji, for their constant guidance and support to the Health and Family Welfare Department. I am thankful to Shri Rajesh Bhushan ji, Secretary Health and Family Welfare, and Ms. Roli Singh, Additional Secretary and Mission Director NHM, for their unflinching support and encouragement. On this occasion, I would like to thank Dr. B. Ashok Babu sir, Joint Secretary RCH, for his constant support to Family Planning Division. I would also like to thank all officers of the ministry who have found time in their busy schedules to attend this important summit. I also thank all the state officials who are present here today to be a part of this important event and who work untiringly with hard work towards improvement of family planning program in their states. India's success in improving family planning indicators has been possible because of each and every individual present here today and millions of service providers and grassroots level health workers who persevere in the field every day. I thank all of them for their dedicated hard work and contribution. Today, I also thank all the participants from the development partners for their dedication towards the cause of family planning in India. I thank all for their presence and contribution to this summit. I am extremely grateful to all our esteemed panelists and facilitators of all the sessions today for accepting the invitation and sharing their experiences. I express my sincere gratitude to Dr. S.K. Sikdar sir for his continued guidance and family planning team for their untiring efforts in organizing this successful event. I would also like to thank the Family Planning Association of India for collaborating with Government of India in organizing this very important summit. The organizing team from India Attitude, our MC today, and as well as the hotel staff who have put in hard work to ensure that the program is a success. I would like to thank all of them. In this summit, several important milestone documents like India's Vision FP 2030, India adapted WHO MEC wheel with inclusion of Synchromen, its digital app version, e-module and e-learning portal of FPLMIS, Family Planning Digital Archive, manuals for the call center executives of National Family Planning Helpline, CHO booklet for family planning, revision of ASHA brochures and leaflets on family planning have been released. I am sure that this summit has provided deep insights for all of us towards improvement of family planning program, and all stakeholders who are present here today will continue to work hand in hand towards achievement of the common objective of enabling universal access to family planning services in India. Once again, I thank you all for being part of this event. Thank you so much.
Can I have your attention, Dr. Last minute. So I think Dr. Sikdar deserves a standing ovation from all of us here today. Thank you, Dr. Sikdar. Thank you for everything over these years.
So ladies and gentlemen, We thank you once again for having joined us here for the National Family Planning Summit 2022 and making it a huge success. I think you all also deserve an applause, so I think we should all applaud for you, the wonderful audience who have made it a successful venture. Thank you and have a wonderful evening ahead.